صباح الخير يا جماعة. Can we get started please? Good morning. Can we have everybody outside? Good morning, everyone, and welcome to the fourth and last day of the workshop. أهلا وسهلا بكم. Today, and the reason why we're running late because His Excellency the Minister of Health will be joining us in the at around 10 o'clock. So we are expecting him any minute. So we will be starting our day, and then we will stop when His Excellency will join us. So today, basically, we are going to be talking about updates and implementation. It's a bit flexible to engage with everybody and to ask for your needs also. Dr. Mernaz, do you have anything you want to add for the day? Maybe you can walk us through.
So, Salaam alaikum, sabah al-khair, morning everyone. Thank you for being with us for the fourth day, which is the last day of workshop. So, yesterday we discussed, we had few exercises to see how evidence to decision framework should be used for guideline development group to make decisions, to make recommendations. Also, we had exercise that how we can use GRADE for appraising the developed guidelines. So today, we will have some sessions, some further considerations about the implementation of guideline, which is, I know that is important from you at the beginning. You ask several questions that how the guidelines should be implemented, what are the considerations regarding the implementability of the guidelines. So we will have some discussions on that. Also, we have a few sessions to talk about some of new guidelines, new version of guidelines, which are rapid guidelines, living guidelines. We will discuss also about those types of guidelines. But before going to that session, as also Dr. Riha mentioned, we will have Excellency Minister with us. Before going to this session, we will have, as you know, requested by some of the colleagues, we will have a presentation which will be delivered by Paul, and he will explain the experience for development and adaptation of guidelines in India, in Kenya, and in Ghana, that what was the process there, what was the challenges, what was the facilitators. So he will explain this experience that, also I think that, they can be very helpful and useful for Egypt as well. So we'll have this presentation, and then we will listen to Nathan. Thank you.
Thank you. We've got the... Good morning. Good morning to you. So yesterday afternoon, people asked about other examples of countries that have been involved in guideline development. And I have only a limited experience here. But overnight, I just put some slides together about some projects that I've been involved in other countries, just to give you a flavor of how the approach was taken, because I do believe that it needs to build on expertise, enthusiasm within the system, and bearing in mind that often the importance and the change that this approach, this GRADE evidence-based approach has as in relation to what happened before, is the injection of a set of methods. And the set of methods relate to the systematic reviews of the evidence and the evidence to decision-making framework. And people are sometimes familiar with these processes, but often not. So these are about collaborations between clinicians and doctors and health professionals that want to do the best for their patients and for their country, but are moving into these new areas. And I remember vividly when I first got involved over 20 years ago with the Malaria Review Committee at WHO, one of the chairs of the committee said, actually, in WHO we need to just, and this was a while ago, we just need to produce what countries should do and then just tell them what to do. And actually, fundamentally, that's just such a flawed argument in my way of thinking. It is, decision-making should be at national and local level. But we, from the outside and from international organizations, should be providing people with the skills and the approaches to help move this forward. So one project we got involved in, this was some years ago, was in Ghana, and we were asked to work with the Essential Medicines Committee, who was not familiar with these processes at all, and there were several drugs to be adopted by the Essential Medicines Committee that, can I just move that in a bit, that WHO had recommended, and we worked with the Essential Medicines Committee to look at these items that they needed to approve and assemble the evidence and help guide the panel in this regard. And the tools that we used and the summaries of the research are available. But just to say, and we've used this example before, WHO was recommending zinc for diarrhea, but actually when the panel considered the evidence, they looked at the systematic review that showed there were fewer deaths with zinc, but actually in Ghana, the mortality rates from diarrhea were low, zinc deficiency was rare, all the trials were done in Asia, and they rejected this and decided not to adopt zinc to be accompanied with the ORS solution or with children with diarrhea. And as I said to you, I gave this example before, WHO was pushing hard that artesunate be used for severe malaria because of this 40% reduction with relative risk. The panel looked at the absolute rate of deaths in the country. There were very few severe malaria cases. There was no quality assessment, quality of assurance of the production of artesunate in the country at the time. It was, but there was for quinine. Health workers were familiar with quinine, and they were not familiar with artesunate. That at the time was IV, and this was also not recommended. So these approaches and the methods used are available in a paper in PLOS Medicine, and we can put that in the Dropbox. But it shows how the importance of adapting sometimes global recommendations to your own context and how it can actually change the decision. There was a group in a pediatric association in Kenya that were concerned about fluid resuscitation in children that were septic. And the FEAST trial had been conducted. I don't know how many of you know about this, but the standard management of children with septic shock is to give them a bolus dose of fluids. And the FEAST trial has been somewhat controversial because it counters what is generally thought to be best practice and showed that bolus dose fluid doses in septic children killed them, or certainly mortality was higher in that group. And one of the interesting things is that the trial had come out and for many years had been dismissed and ignored. It's a very, very well done trial. And so the Pediatric Association was concerned about this and 2 other topics. So they didn't have a lot that they didn't have a lot, hydroxyurea, its use in sickle cell, and 1 or 2 other things they had. But they didn't have a lot of topics they wanted to discuss, but this was an important one, treatment, fluid, whether to use bolus treatment. And no systematic review had actually been conducted at the time, so a systematic review was done, incorporating FEAST and critically appraising the FEAST trial. There was a guidelines panel was set up. People met at the pediatric conference, and they had 3 guidelines panels to discuss the 3 questions. One of them was about the fluid resuscitation, and then that was introduced through the Pediatric Association as standard practice, and so that they ended up modifying the bolus dose in the country in the emergency treatment of sick septic children. So quite a focused area, but obviously an area of importance. And that's also written up somewhere, the experience with that. So then lastly was the Index TB guidance in India. And this was a really, for me, was probably the most exciting project ever I've been involved in, and having worked in India for over 25 years. But there was a professor at the All India Institute of Medical Research called S.K. Sharma, who was a very senior person, who was a very collaborative, a very kind person, and worked well with people, and he genuinely wanted to get guidelines out because he felt extrapulmonary TB was being badly treated in India, and he'd been trying for a long time. He was working closely with people in Cochrane, at the Cochrane Centre, and decided to work with us in this. The government was really interested because suddenly the clinicians were interested in the additional program for tuberculosis control across the country, so there was a lot of money for. So the government was really pleased specialists were engaging in TB. And in the first phase of this organisation was the initiation and scoping meeting. The central government initiated this. Medical colleges started drafting clinical guidelines across many organ systems for basically clinical manuals for treating TB. You know, what you would do, what tests you would do, when and what would you admit, and what fluids you would give. Huge amount of work. And actually, its relation to evidence was not entirely clear, and it sort of reflected what people were generally doing as best practice. And so there was a big meeting with over 150 people discussing progress to date. And we said, well, yes, these are clinical manuals that can help care, but where are we going with this evidence-based approach? We need something a bit different. Now, this is terribly small because I didn't have much time, I'm sorry. So we said, we need to slightly change direction, and we need to develop things further. We need proper guidelines groups. So that people set this up. I'm sorry, I just didn't have time to get this quite straight. But the structure of this in the first phase was a core committee was set up with people in TB. There was a technical advisory committee that advised them, the guideline review group that made the decisions, a peer review group, a methodology support team. And so what I think is important is to point out that there was an overarching system of governance and control centrally with the core team, and that they had also a guidelines review committee that we had here in the fishbowl that made the decisions on various aspects, and there was a methodology committee that did quite a lot of the work with the reviews and so forth. but it's simply to point out that a structure is required. It was quite a big effort. This is the core committee, a smaller group in Delhi. And these are the three, these were three of the 5 methodology people producing the systematic reviews. Pratap ran the Cochrane Centre there. And a lot of it was about dialogue, about getting across ideas. This is Hannah, who was a young clinician who worked with me for a little while. So what came out of the first meeting was that we should focus on 3 areas. The use of gene expert in extrapulmonary TB, and we focused on these 3 questions. Should it be used in lymph node TB or pleural TB? Should corticosteroids be used routinely in TB meningitis, pericarditis, and pleural TB? And how long should you treat lymph node TB, abdominal TB, and TB meningitis? These were seen as important questions to address. And so the guideline committee, so then over a period of about a year, it did take some time to pull the reviews together. We updated diagnostic reviews. We produced grade tables of the diagnostic tests. And we had our own evidence to decision-making framework, which was before the WHO type evidence to decision-making framework had been invented to go through all of this. And it's terribly small, but what I'm saying is an organized process of identifying the questions with the topic specialists, then assembling the evidence carefully that would inform their next meeting when they discussed what they were going to recommend. And I'm nearly finished now. This was some of the changes, some of the things that we did not expect. In TB pericarditis, the initial draft summarized the effect estimates. So when we gave the guidance, the guideline review group, this initial summaries of the initial systematic review, we summarized the effects from one large study which aggregated HIV positive and HIV negative people. And the guideline panel said, that's no use to us because we don't have much HIV here. And we had to go away and reassemble the evidence to separate these out. And in TB pericarditis, the initial review had mortality as a critical outcome. And the clinician said, no, mortality is important, but we're also keen to know about long-term disability. So we want you to extract the data on long-term disability. And finally, TB pleura, and this one was completely unexpected. The critical outcome in TB of the pleura was for the panel was a long-term disability. Well, we thought it was long-term disability, but their critical outcome was whether corticosteroids affected the chest X-ray, because this influenced whether people could get jobs overseas when an X-ray was taken. So they wanted to know what the effect was. So, yes.
Thank you. Let me ask you one question, please. Here the question remains, why they didn't save time, all of these systematic reviews and evaluating these systematic reviews, and use the already present WHO guidelines, which is for sure depend on previous systematic reviews. So why at the national level they did all this effort while the WHO guidelines is already present with the evidence?
So WHO didn't really cover extrapulmonary TB extensively. So some of this was new because there were gaps, and it's India. They don't necessarily want WHO guidance. And so the questions that they were asking then needed then needed the reviews. But then when they saw the evidence, they said, actually, this evidence isn't very useful to us. No, they did. The evidence around corticosteroids, there is not a WHO guideline about corticosteroids in TB, I don't think. So they developed the questions, and then the reviews were developed, and then they actually said, well, actually, this isn't quite what we want. So the reviews had to be modified in the light of the questions that they had. Can somebody... Yes.
So that was an excellent question. And so this is the case of the country had a question, a PICO, that was not covered by WHO guidelines. So that's one thing that Paul sort of highlighting. So you see, when we talk of adaptation process, you look at the guideline, but you start from your own PICOs. So absolutely. So if WHO is not responding, then you have to do something for that. The other thing that Paul is highlighting is that you also, when you want to adopt or adapt another guideline that exists, whether it's WHO or any other source, you're also seeing that whether the evidence is the one that used the basis of that guideline is also relevant to your context as well. If you don't see, then you try. Obviously, with WHO guidelines, a lot of care is being given to make sure it's all there, but still that's the question you ask yourself. And then if another source coming other than WHO, then obviously you do give it more attention.
If on the national level, on the country level, we decided to use the WHO guidelines because it replied to my PICO question. Hence, I should reassess the WHO guidelines.
So what we're saying is that this process of adoption is not quite as simple as it seems. And the first example I gave with Ghana, WHO assumed that the country would adopt what they had strongly recommended, the zinc for diarrhea and the artesunate. They thought it was a no-brainer, and the country actually paused. It rejected one and paused the second, because of circumstances within the country. Some circumstances related to zinc deficiency not being a problem, and the other was that their health system wasn't ready to go with this, so they didn't think it was a priority that year. So, and now the TB examples are a little bit more complicated because global evidence, the guidance hadn't come out. Indeed, the recommendation globally was that probably that corticosteroids should not be used because of this trial. India actually influenced the global evidence base by forcing a disaggregated analysis which showed benefit of corticosteroids in people that were HIV negative, which wasn't there before. So it's these questions that people ask at a national level can actually be very important and should not be, you should not assume other sources have got it right, that it doesn't fit, that, you know, WHO must have it right or the Americans must have it right. You know, you should be considering it not only in terms of the evidence that you're looking at, but also the applicability in the system in terms of epidemiology and so on. So the only thing I would, that was a quick presentation related to the India guidance process, which took over several years. It was a very constructive process. The guidelines we can put in the Dropbox for you. The things that we learned from this was that political will and a desire by all stakeholders to adopt new methods for guideline development were very important to the success of this project. So these are all points that we think helped success. That there was methodological direction independent of the clinical specialists to guide the process. So there were methodologists working with the clinicians hand in hand to keep things in line. Not because the clinicians were necessarily wanted to do the wrong thing, but just to help people through the methods, getting conflicts of interest sorted out and so forth. It needed evidence synthesis people with dedicated time to summarize the evidence. So quite often people keep saying, oh, well, we'll just adopt those guidelines or we'll just adopt that systematic review. It isn't always as easy as that. You often have to do additional analyses and look at things in different ways. And the last thing that was important was government's input into this. So the central government TB department, which is a powerful group in India, a central core from government with authority was overseeing the process. They were in on all the meetings and watching what was going on and required to see all the documentation as we went forward of due process. So that's, thanks for listening to that. It was all a bit of a rush, but are there any questions or comments about these case studies?
Guidelines help us to focus decisions whilst also taking personal values and the preference individually circumstances of patient into account. This maybe answers the questions of why national guidelines is important, because we adaptations, it is not obligatory, it gives us just provides specialists with evidence-based information and documentation for management of disease. It must be emphasized that clinical guidelines present the best evidence available to the experts. But the following guidelines or recommendations will not necessarily result in the best outcome. Guidelines can never replace the clinical experience, judgment when making treatment decision for individual patients. But rather help to focus decisions while also taking personal values, preference, individual circumstances of patient into account, which is so important. We have national guidelines to adapt this. Guidelines are not mandate, doesn't purport to be a legal standard of care. This is conclusions why we need our national guidelines. This is introduction of every chapter in European guideline. It gives this paragraph before every chapter. So it is, I think it is summarize why we need national guidelines.
One of the examples I didn't put in, and maybe we should bring the slides up later, is we worked with a national committee in India that used this model for COVID treatments, and it was very clear that people weren't really taking much notice of WHO, but they sort of saw the WHO guidelines, but it wasn't Indian guidelines, right? And they wanted guidelines, and the process. So some people keep talking about, oh, it's just duplication. Why is everybody duplicating? But I was in on most of. I was part of the panel in the background on many of the discussions, and people needed to go, clinicians in the country, through the evidence base, through the trials, and make their own decisions about when you use oxygen, how low the O2 goes before you use oxygen, when you're short of oxygen in the hospital, when you're going to use this drug, what about severe conditions. And so there was a real need to internalize it, and many of the decisions, often the recommendations were rather similar to WHO and others, and they would often compare them with those during the process, but sometimes they weren't. But there was a process of internalizing the evidence that meant the implementation of those guidance was more likely because it made sense in the context that these clinicians were working.
Dr. Arash, you may want to add to what I am about to say, but we talked yesterday a lot about the evidence to decision-making process, and the different domains that you consider are the safety and efficacy of the intervention, which is supported by a systematic review of the evidence, and then you have the other considerations, values and preferences, feasibility, resource use and equity. And I would suggest that the safety and efficacy part, the systematic review, if the systematic review is done well, there is no need to repeat that component at the national level, because the evidence will be the same whether 5 different people do, if 5 different groups do a systematic review and they do it well, they will come up with exactly the same answer. So that may be redundant to repeat the systematic review. However, the other domains, values and preferences, feasibility, acceptability, cost, those have national relevance. And so, okay.
Okay.
And so it's simply to say that when an international guideline is getting adopted at a national level, there may be these local additional components of information that need to be looked at before the guideline is adopted.
So, further questions? Yes, ma'am.
Well, thank you, Paul. Well, actually, I need to ask and summarize in the same context. So, if we pick a review from the literature and we are happy for it, we have to transfer it to our PICOs, because it may be so different regarding which PICO that the guideline, the international guideline is here and there. So, am I right?
So I'll just finish this comment. And then pass to Sir. So the first point, a guideline panel would, if they're adopting a systematic review, they would still go through the grade system in order to consider the grading of the evidence. So they may downgrade on indirectness, or they may use the systematic review, but they may alter the certainty of the evidence in the light of the application to the country's health system. So they must consider it. They don't adopt it wholesale. They need to internalize the methods and the analysis as we did here. Thank you.
يعني جلستها خلصت. تبي تسمع أكثر؟ صباح الخير، صباح الخير الوجوه الخيرة. احنا جدا سعداء بالتشريف معالي الوزير دكتور خالد عبد الغفار اليوم، وقيادته لهذه المبادرة كمنظمة الصحة. نشوف هذه المبادرة مبادرة رئيسية. معاليك بعد إذنك أتكلم باللغة العربية من الإنجليزية. I would like to welcome His Excellency the Minister Dr. Khaled Abdel Ghaffar, Minister of Health and Population. He is very well known. Your Excellency, today you have different disciplines here, multidisciplinary, multisectorial, under your leadership. Next to me on my right is Dr. Arash Rashidian, and he is the Director at WHO Regional Office, responsible for the whole scientific innovation and research for health development. More importantly, we are also having from, I don't know whether Paul, can you stand so His Excellency sees you? Dr. Paul Garner, Emeritus Professor, Liverpool School of Tropical Medicine, who has been a key expert with World Health Organization, internationally very well known, and he has been bringing his experience to Egypt. Dr. Nathan Paul, Chair. Nathan, you are too short like me. Chair Nathan Paul Ford, and he is the chair of the Guidelines Review Committee at the WHO headquarters in Geneva. Nathan Paul has been very active in this and has years of experience, because this is an area, Your Excellency, that you are leading is very, very critical for WHO, and Dr. Arash will share his view on it. Dr. Edith Patron, who is the senior health economist, She is the Economic Evaluation Analysis Unit from WHO Geneva. She was with us. She has left yesterday, but promising that she will be coming back. So we are linking your leadership, Dr. Malik, in this area to also the economic value and related to the health value. Definitely, I would like also just to be very short, introduce, beside Dr. Arash, Dr. Mehraz, who is the regional advisor for this area, and she is responsible, has been responsible in various pharmaceutical. Dr. Mehraz is there, and she has been working very closely with the chairperson, Dr. Mohammed Fawzi, with the team. This is second detailed workshop, but we already had a 2 days workshop. And Mehraz is known more than me to most of this group because she spent actually visiting the sites before this workshop. And we have also Malika, who is a young working professional working with Dr. Arash. And I would like to thank Dr. Riham Asadi, who has been leading this work closely, working with Dr. Mohammed Fawzi beside the team. We have Jasser. I don't know, where are you, Dr. Jasser? And the whole team are around, Dr. Ahmed Khalifa, Amira Hijazi. Your Excellency will be very short because we know that your time is very much needed to discuss with the team, but there are 3 messages I would give with the permission of the distinguished, respected senior officials here, all of you with مع حفظ الألقاب والمقامات. The first, your political commitment, Your Excellency. This is Dr. Paul and the team really confirmed this. The whole discussion in terms of bringing all the stakeholders around. This is not an easy job, he will say it. And more importantly, the approach that has been used. We are very proud that we'll have a roadmap, inshallah, strengthened after this workshop. I want to give at this point the floor to Dr. Arash Rashidian and then to Dr. Fawzi to tell you where we are.
Okay. Sabah al-Khair, Assalamu alaikum. Your Excellency, it's a pleasure to have you with us in this agenda. And it's been a pleasure to work with your team, your colleagues within Ministry of Health, but also other stakeholders in Egypt for this key program. So my role is for the region, the areas of science information and dissemination. But then this program is very much related to a resolution in 2019 when the ministers of health of the region requested WHO to do more work in areas of evidence to policy processes. And that work, I mean, we had the resolution in 2019. COVID hit all of us in 2020. So we had to adjust in WHO to respond to COVID requirements, including the use of evidence for that response. So then we prioritized 3 countries of the region, 1 high country, 1 middle-income country, 1 low-income country, because of the capacity building that they wanted for evidence-informed processes. And those countries were Kuwait, Somalia, and Morocco. Then we had, Your Excellency, your request a few months ago from the regional director, and then also through Dr. Naima, the issues of the National Guideline Program. And I can tell you, as the regional program, we were delighted to have the request, not because we felt that's easy to respond to, but because of the way it came as a national agenda. So for 3 other countries that we are working, we are actually working on the whole process of evidence to policy. But for Egypt, the focus is very clear, the national agenda for guideline. And this is the first country in the region that actually came with the request so specifically, and I think so very much linked to the agenda. And we felt also your previous responsibility at the Minister of Higher Education also was part of that issue. So the credibility of the sort of the agenda and the importance of it for the health sector, we felt it, and we felt it as a demand. And also we have an excellent WR, Dr. Naima, who is, when she's following something, she's really following. And the team together, we work really hard on this issue. For us, it's been so what we have seen is the commitment of Dr. Fawzi and his team, and the sort of perseverance of all the teams, the players that are here with us. I mean, this is our 2nd workshop. The previous workshop, Your Excellency, it was more of a political level, political engagement. The heads of different stakeholders were present. The reason for that workshop was that those who run the agenda, they need to know what should be happening underneath their leadership so that they support it. Here today we have also leaders with us, but many also technical colleagues who are going to do the work. They are going to be based on the guidelines. And what I'm going to finish with is that we are also delighted to see the openness of the discussion. People are open to criticism, people are open to challenge the ideas, and that's what you really need in a national guideline program. Obviously, as WHO, and I'm proud to also be part of the WHO guideline development with my colleague Nathan Ford. But when we issue guidelines, the whole purpose of that guideline to be implemented. That's the whole purpose in the best way. And if the country doesn't have a national guideline program, that's not going to happen. On the other hand, WHO guidelines are only on a few limited topics, while the needs of the countries are much bigger, much more expanded. And the third point, that we were also part of that discussion that Paul was just coordinating a few minutes ago, is that the questions that the country has not necessarily are addressed fully in the WHO guideline. With all of that in mind, then what would be a credible program, a process that is timely, cost-effective, and responds to the country needs? And with your team, Your Excellency, and with the WHO team in country office, we hope that we will be able to help the country of Egypt to establish that program. And what we are doing also, the extent that the regional office is working with the country office for this program, and also the headquarters, we will not be able to do that for all countries of the region. But for us, it was important to do it for Egypt, because then we can showcase it, how it works for other countries of the region. And we are hoping that in the upcoming regional committee, there will be a pre-RC discussion on national guideline programs, and we will demonstrate the case of Egypt in that discussion as well to other countries of the region. I stop here. Shukran.
Thank you very much, Your Excellency. This is happening in October, so we are talking about preparation. Dr. Fawzi and the team and all the distinguished committee members will have a challenge to expedite working, and with your support, with your commitment. We are very also happy, Your Excellency, Dr. Fawzi will be giving you more picture, because you asked who is around the table. We are having academicians, scientists, researchers, clinicians, the dignitaries of the different sectors, whether it's primary or hospital, but also the syndicates. So you have a diverse, and we have what I call the wise, and the wise young. So I will not say the age, but that's the... Dr. Fawzi, if you would like.
Firstly, I would like to thank Dr. Khaled Abdul Ghaffar to give us this opportunity to have our own national guidelines. And he is insisting that we should make it, not take it as a ready-made, and to share all stakeholders in this process, not only one. And I hope that we can do this mission satisfying the requirement. We started, as mentioned before, to have 2 workshops of training, and then next step will be that we will start in the center of guidelines in material teaching hospitals, and we will form the subspecialty committees to start as soon as we can. We are waiting for the expert from WHO that will help us and stay for 2 months with either continuous or other period, whatever they agree. As I see from this training workshop, I hope we have made it so easily and rapidly. I found that all of us are motivated and they are efficiently. We discovered some miracles in this workshop, and I hope we will start it as soon as we can. Thank you.
Thank you very much, Dr. Fawzi, and indeed he has been after us. Your Excellency, I told him that you wanted, on my opening speech, that you wanted this 100 years ago, because you have been Minister of Higher Education and Scientific Research, and I was saying to the experts, Dr. Paul and Dr. Nathan, that you were also at one point, 11 months, you had the 2 portfolios, and that was your drive. So we really look forward to work with the Minister of Higher Education and Scientific Research, with your good self. But at this stage, I have on this stage, Your Excellency, with your permission, would like also to congratulate His Excellency Dr. Mohammed Lutayef, who has been just appointed Rais al-Majlis al-Sahi al-Masri. So he is I already introduced, he is new, brand new. We talked about you that you are brand new, but not new, because you already have worked with the minister, and also you have been chairing with the higher education. But this brings the university teaching hospitals, Your Excellency. They are also here. At this stage, I don't know, would you like Dr. so people can hear your voice, and then I will give the floor to His Excellency to guide us and to say his expectation where to go.
Thank you very much, Dr. Naima. Your Excellency, Professor Khaled Abdel Ghaffar, Minister of Health and Population, Dr. Naima Al-Qasir, WHO representative in Egypt, Dr. Muhammad Fawzi Soda, President of the General Organization for Teaching Hospitals and Institutes, Dr. Arish Rashidian, Director, Science, Information and Dissemination, WHO, EMRO, distinguished senior officials, my medical colleagues, I appreciate the engagement that you will have contributed to the technical workshop on National Program for Guideline Development and Adaptation in Egypt, which is one of the major mandates of the Egyptian Health Council. In the beginning, please allow me to give you a short introduction of the Egyptian Health Council, which I am honored to be the first executive president. The Egyptian Health Council goes in line with the Article 18 of the Egypt's 2014 Constitution, which states that every citizen had the right to receive integrated health care in line with quality criteria, and the state shall do its best to preserve and support public utilities which provide the people with health services, and shall raise the efficiency of these utilities to ensure that they are spread everywhere in Egypt. Accordingly, Egypt has been moving by leaps and bounds to reform public health services in the form of presidential initiatives aiming to create a comprehensive health insurance system, improving the performance of medical education, raising the living standard of medical teams in Egypt. Among the steps taken was the establishment of the Egyptian Health Council law. In March, His Excellency President Abdel Fattah el-Sisi ratified the Egyptian Health Council Law number 12 of year 2022 after the Parliament approved in its plenary session. The new law on establishing the Egyptian Health Council comes as a new step towards raising the quality of health services and providing medical teams with high-quality training to cope with the latest developments in international health sectors. In this context, the Egyptian Health Council will be created to replace the Egyptian Authority for Doctor Training, which was established by government decree in 2016. Article number 1 of the Egyptian Health Council law stipulates the establishment of the public service body under the name Egyptian Health Council with the legal personality and affiliated with the President of the Republic, and its headquarters will be in the city of Cairo. And the council may include other branches in the governorates. Law number 12 of year 2022 sets the objectives of the Egyptian Health Council. As Article 2 of the law stipulates, the Council aims to, number 1, regulate some fields of health in Egypt, whether in post-university education, specialized training, or developing the scientific and clinical level of various doctors with workers in all medical specialties. Number 2, develop the level of medical training for various doctors and workers in all medical specialties. By all medical specialties, I mean medicine, dentistry, pharmacy, physical therapy, nursery, and veterinary medicine, as well as for graduates from medical and health colleges, through testing them in order to verify that they are all meet sufficient qualification for safe health and medical practice. Number 3, ensure the improvement of all health services within the Arab Republic of Egypt in accordance with the state's general medical and health policy. Number 4, achieve both integration and cooperation in the field of health training among the council, bodies, and various scientific councils in the same fields of specializations, whether inside or outside Egypt. Number 5, which is the last aim, is to achieve various international standards for safe health practice, keeping pace with the Egyptian Health Council for scientific progress. We will develop our standards and our guidance through consultation with a wide range of people, including patients, doctors, employers, and educators. We will make sure health professionals get the education and training they need to deliver high-quality care throughout their careers. We will do this by setting standards for postgraduate professional medical education, in between brackets, the Egyptian board, and by monitoring training environments. We will help maintain and improve standards through revalidation. It's important that every licensed health professional in Egypt is keeping their knowledge and skills up to date. In these substantial changes in the health system, it's equally important we need the changes in attitudes of health providers, patients, and the community as a whole. Your contribution as distinguished experts will be of paramount importance in illuminating the way forward in this huge undertaking. This is a short brief about the Egyptian Health Council, which, as I've said, and I'm honored to be its first executive president. Second part in my short speech, if you can please allow me, about this workshop, which there are 2 different types of healthcare guidelines. The practice guidelines, and I'm sure that you know all about it, and treatment guidelines. Practice guidelines consist of recommendations to professionals concerning their conduct and the issues to be considered in particular areas of clinical practice, rather than on patient outcomes or recommendations for specific treatments or specific clinical procedures at the patient level. But treatment guidelines, which are the focus of this workshop, provide specific recommendations about treatments to be offered to the patients. That is, treatment guidelines are patient-directed or patient-focused as opposed to practitioner-focused. And they tend to be condition or treatment-specific. Example, pediatric immunizations, mammography, depression, etc. The purpose of treatment guidelines is to educate healthcare professionals and healthcare systems about the most effective treatments available. When there is sufficient information and guidelines are done well, they can be a powerful way to help translate the current body of knowledge into actual clinical practice. Many treatment guidelines are disorder-based. The most common classification system is the International Classification of Disease by WHO in 1992. The disorder-based approach has limitations. Patients commonly present issues that cut across diagnostic lines. Dual diagnosis, comorbidity are common, and disorder-based diagnosis is often a weak basis for determining appropriate levels of care and other characteristics of treatment. Other classification systems, such as the World Health Organization Functionally Based International Classification of Functioning, Disability and Health, World Health Organization 2001, might also provide the basis for the development of treatment guidelines. It's important for groups constructing or evaluating guidelines to consider the adequacy and limitation of the nosological systems on which they are based. Healthcare professionals are in the best position to be aware of the unique characteristics of individual patients. The treatment strategy most likely to succeed usually combines the most effective specific interventions with a strong therapeutic relationship and mutual expectations of and framework for improvement. Such factors, which are common to most treatment situations, can be powerful determinants of treatment success. Good guidelines allow for flexibility in treatment selection so as to maximize the range of choices among the effective treatment alternatives. The judgment of healthcare professionals, although always needed, is particularly important in treatment conditions for which research data are limited. Guideline panels should take these factors into consideration and particularly should avoid encouraging an overly mechanistic approach that could undermine the treatment relationship. It's often assumed that the use of treatment guidelines would significantly reduce the cost of services. This is not necessarily true. It's possible that guideline implementation may cause some services to be discontinued because of evidence documenting an intervention lack of efficacy. However, it's also possible that adoption of guidelines will lead to a shift toward more effective, but not necessarily less costly services. And it's possible that more costly or additional treatments will be recommended. Another common assumption is that standardizing treatment via guidelines will also be beneficial because it reduces practice variation. However, variation in clinical practice is often based on the needs of individual patients and their responses to specific treatments. When the application of the guidelines results in a rigid system that eliminates the ability to respond to individual needs of the patients and the opportunity for self-correction in treatment, this can be detrimental to patient care. However, burden of proof remains on the makers of each guidelines and those responsible for its implementation to establish that the application of the guideline is indeed beneficial and doesn't impair patient care. Treatment guidelines have the potential to influence the health care of many patients, and therefore the guidelines and the process used in their development should be open to public scrutiny. Moreover, failure to disclose the scientific justification for guideline violates a basic principle of science which requires often scrutiny and debate. Without the disclosure of adequate scientific information, guidelines are mere expressions of opinion. It's important to recognize that the term guideline generally refers to pronouncements that support or recommend but do not mandate specific approach or actions. In this regard, guidelines differ from what are sometimes called standards, in that standards are considered mandatory and may be accompanied by enforcement mechanism. The criteria for evaluating treatment guidelines should be regarded as guidelines, which means it's essentially aspirational in intent. It's intended to facilitate and assist the evaluation of treatment guidelines, but it's not intended to be mandatory or definitive and may not be applicable to every situation. Thank you very much again for allowing me to give you a brief about the new Egyptian Health Council, and at the end I need to give my great appreciation and thanks for Professor Khaled Abdel Ghaffar for appointing me in this job. Thank you very much.
Thank you very, very much, Excellency Dr. Lutayef, and you gave a whole vision of what you want to do beside the law. I think we have a lot of common understanding of where we want to go and how we can support you. I would like to, maybe we'll come back to you, and Dr. Arash, I said, if you have time later, you can sit with with the experts, especially on that standardization versus the guidelines, versus the evidence-based for diagnostics and treatments, and compared to what should be done for the general. So this is something we can discuss more. His Excellency, Dr. Khaled, Prof, is asking a couple of interventions from, maybe I'm too short, but he would like to hear from some of the participants If you can please speak and you can speak in Arabic, ممكن تتكلمون باللغة العربية. معالي يريد يسمع من المشاركين والمشاركات في البرنامج في خلال 3-4 أيام الماضية. إذا نشوف كم مداخلة من الجماعة. دكتور حسين طبعا.
Bismillah ar-Rahman ar-Rahim. Thank you very much for allowing me to participate and attend this meeting. I'm going to speak in Arabic because it's very important issues that need to be applied in Egypt. There are 3 points: the mechanism of doing the guidelines, then who is going to lead the process itself, and it must be implemented and be unified all over the country, and it has to consider the economic value.
This is not Arabic يا دكتور.
لا ما أنا هبتدي بقى. أنا قلت الأربعة الأولانيين، ال4 نقط اللي هتكلم فيهم، وبعدين هبتدي ألخصهم بقى. الميكانيزم احنا عرفناه خلاص من الورك شوب اللي اتعمل، وازاي نعمل جايد لاينز، دي أول نقطة. الحاجة الثانية مين اللي هيقود العمل؟ احنا عندنا المجلس الصحي المصري، عندنا الجمعية الطبية المصرية بالجمعيات الأهلية، عندنا اللجنة اللي اتشكلت برئاسة الدكتور محمد فوزي، عندنا التأمين الصحي، عندنا العلاج على نفقة الدولة. دي كل دي 5 أو 6، الجامعة طبعا ووزارة الصحة وهيئة الرعاية الصحية، فلازم حد يقود العملية وإلا الأمور هتبقى فيها اوفرلاب وفيها نوع من اللخبطة يعني. وده طبعا احنا في وقت محتاجين فيه بسرعة ان احنا نعمل الجايد لاينز دي، لانه الموضوع يعني عاجل جدا بالنسبة لنا كمصر يعني. دي تاني نقطة. النقطة الثالثة بقى، احنا مرينا بالموضوعات دي كتير قوي قبل كده من سنة 2008 واحنا بنعمل جايد لاينز، وبالذات في مجال علاج الأورام اللي هو الأونكولوجي اللي هو تخصصي أنا. الحقيقة المشكلة الحقيقية مش إن أنا أعمل جايد لاينز، هي المشكلة الحقيقية إزاي أنا implement الجايد لاينز، وإزاي أجبر الناس اللي هم بيشتغلوا سواء في الصحة أو في التعليم العالي أو في القطاع الخاص أو في القطاع الأهلي إن هم إزاي يفولوا الجايد لاينز دي. ابسط حاجه ان انا هقول اللي هيمشي على الجايد لاينز دي هو اللي الحكومه او الدوله هتدفع تكلفه العلاج بتاعه، اللي مش هيعمل كده خلاص هو حر. اخر نقطه الحقيقه ان احنا لازم نراعي الجانب الاقتصادي في عمل جايد لاينز في مصر، لان احنا طبعا يعني سهل قوي ان انا احط جايد لاينز على اعلى مستوى لكن في الاخر ما اعرفش انفذها، وده الحقيقه بيحصل كان في الفترات السنين اللي فاتت. الNCCN جايد لاينز اللي هي الولايات المتحده تقريبا ماشيه عليها، عامله هارمونايزد جايد لاينز، وابتدت تعمل ريجنال جايد لاينز من الNCCN، تعمل الكاريبيان اريا وبتعمل للسب سهارن افريكا. والفكره في اللي بتعمله للسب سهارن افريكا وفي الكاريبيان اريا، وانا اتمنى انه يتعمل حاجه للنورث افريكان ريجن، لان يمكن احنا في النورث افريكان ريجن مختلفين شويه عن السب سهارن افريكا. بيحطوا هارمونايز جايد لاينز، بيحطوا الوان، لون اسود ولون رمادي ولون ازرق، بحيث ان هو كل لون من دول على حسب الفايده الاقتصاديه الكوست افكتيف بتاعه. بالتالي انا اقدر ان انا، او بيسموها لو كيس سيناريو، ميدل كيس سيناريو، هاي ليفل سيناريو، ومش كانتري سيناريو اكتر، لان جوه كل بلد في المستويات المختلفه دي، وعلى حسب البادجت اللي بتبقى متاحه، على حسب ما انا اقدر ان انا طبعا في مقوله سياسيه بتتقال، لا احنا ما عندناش مشكله في الفلوس، احنا نعمل الجايد لاينز المفروض انها تتعمل، بس في الاخر على ارض الواقع، والواحد مارس هذا الكلام في ال30-40 سنه اللي فاتوا، ان احنا على ارض الواقع بنلاقي شورتج موجود، بنلاقي الادويه ما بتجيش بالصوره اللي مطلوبه، بتلاقي العيانين بياخدوا ادويه مش المفروض ان هم ياخدوها بنلاقي ان جزء من البروجرام اللي هم يمشوا عليه بقى جزء متقطع وجزء لا. دول الاربع نقط اللي انا عايز اقولهم، هقولهم تاني باللغه الانجليزيه.
شكرا دكتور. احنا دكتور اراش مستوعب اللغه العربيه ويريد يرد على بعض الملاحظات. دكتور خالد شكرا جزيلا على دكتور حسين على مداخلتك. احنا كنا حابين بعد نسمع لان ما طرحت حاليا الاربع ملاحظاتك تكلموا الخبراء اللي موجودين مش منظمة من الخبراء المصريين في هالأربعة أيام الماضية. بس بعطي مداخلة قصيرة دكتور أراش. دكتور His Excellency has to leave. So, no? Okay. All right, then I will give another floor to another person. Dr. Hussein, I made note of everything you mentioned before, and there is a whisper translation in English. دكتورة هناك وبعدين دكتورة كوثر. تفضلي.
My name is وسام إسماعيل. أنا أستاذ باثولوجي في جامعة بني سويف with a subspecialty of renal pathology. And
صوتك مش واضح.
أوكي كده واضح. we participated in the Egyptian guidelines of transplantation. And the Egyptian guidelines of transplantation was a mix between what we consider practice guidelines and management guidelines. And it was a major كان حاجة من major considerations اللي we had was إن هي تبقى زي الconcern بتاع كل الناس إن هي تبقى applied للlocal practice بتاعنا. I agree إن guidelines should not be mandatory بس الحقيقة guidelines بتhelp a lot of the juniors الناس اللي معاش a lot of experience that they can go back to the guidelines and see what they can do, get a review of what's in the literature. The process and the methodology we used in our guidelines were actually, we did not do a systemic meta review of the literature again because it was already done, but we did review all form of guidelines which was already related to the subject. So I just wanted to comment that yes, guidelines are not mandatory, but they could be very useful and very important for clinicians to get back to when they are confused or when they want to get new information.
Thank you. We'll give one more intervention. Dr. Kauthar, you raise your hand. Dr. Sharif. Dr. Kauthar, very short, please.
السلام عليكم. أنا بس عايزة أشكر في الحقيقة معالي الوزير على يعني مشاركتنا. احنا عاملين كنيرسينج كلينيكال جايد لاين بالتعاون مع WHO من 2014 وعملنا لها تحديث 2018 وجبنا مجموعة متخصصة من أساتذة الجامعة. في الحقيقة الاستفادة من الوركشوب ومشاركة التمريض فيه إن أنا شخصياً عرفت بعض الديتيلز التكنيكال وبعض الريجوليشن اللي كانت مزد مننا في إعداد الجايد لاين. إن شاء الله لما نيجي نعمل أبديت هنراعيها. أنا كنت طلبت من دكتور معالي الوزير من دكتور محمد فوزي إن خطوة كويسة جدا إن إحنا نعمل للدكاترة والتمريض محتاجين لباقي الفريق ومحتاجين كمان بعد ما نعمل أبديت. أنا بتكلم على النيرسينج. يمكن دكتور حسين اشار للجزء ده وايد ديسيمينيشن لكل التمريض في مصر. احنا مهتمين يمكن بوزاره الصحه لكن احنا عايزين الجايد لاين ده تمريض مصر كله بعد ما نحدثه يستفاد منه. شكرا جزيلا.
اخر مداخله من المشاركين في خلال 3 ايام الماضيه. اوكي يس ميرناس. give the floor to. شكرا دكتوره كوثر. احنا اخذنا مداخله دكتور حسين بخصوص الديسيمينيشن والتطويع. دكتور مراد.
محمد مراد عبد السلام, consultant obstetrician at GUSI. First of all, I want to express my gratitude to His Excellency Professor Dr. Khalid Abdel Ghaffar, Minister of Health and Population, for having the vision to start this program for national guidelines in Egypt. I will raise 2 points. First, that we have to start as soon as possible to make use of the momentum that has been created by this workshop. And the second thing that I want to emphasize that developing national guidelines is a continuous process and not a program for a certain period, because even guidelines that will be developed we need to be updated regular. Thanks.
طبعا اشكر معالي الوزير على الاهتمام الخاص بالفكره الجايد لاينز والمنظومه والارضيه ان احنا ننزل عليها، لان دي مهمه جدا. انا عايز اقول كلمه واحده بس، الجايد لاينز مهمه for the safety of the patient, safety of the physician and safety of the country. الثلاثه. Yes. It's not ان انا اخد فلوس واخد خالص. For the patient العيان هيمشي في الطريق الصح، the right way, right track. For the physician أنا بحمي الطبيب في المسؤولية بتاعته، بحافظ عليه وأحمي عليه. الكانتري لو هنيجي على آخر المنظومة حسبناها كل سنة هتلاقي الفلوس قلت عكس ما أنتم متصورين، لأن أنا الجايد لاينز متمثلة في الانفستيجيشن، التريتمنت، الدايركت تريتمنت وهكذا. فأنا بتكلم لما أتكلم على الجايد لاينز I am talking about the safety of the patient, safety of the country and safety of the physician. هي دي أهم حاجة عندنا، وده الفكر بتاع معالي الوزير اللي اتكلمنا فيه. ما تخافوش، الناس هتطبقها في مصر. أهم حاجة عايزين تاخدوا مثال البروتوكول والجايد لاينز اللي كانت في الكوفيد 19 اتطبقت في البرايفت سيكتور، في الميليتري سنتر، في اليونيفرسيتي هوسبيتالز، لانك انت بتجبر نفسك انك تمشي في هذا الطريق، والا هيبقى فيه محاسبه لو انت ما مشيتش عليه. فالتطبيق ما تخافوش منه، حطوا الجايد لاينز سهله according to the place, according to the urban area, village، اي حته، وهتمشوا عليه. ما نخافش خالص، الموضوع هينفذ في مصر. It's very easy and to be renewed every 3 or 6 years.
Thank you for positioning the safety. Dr. Arash is requesting to respond to some critical so we don't have confusions between guidelines and standards and the direction, Your Excellency. I have someone who had stood 3 times.
Okay, many thanks, colleagues. I mean, very important points were raised. I understand. Oh, okay. So I understand Arabic when colleagues also speak more slowly, so I may not have caught everything that needed, but I reflect. One key point about what Professor Lataif mentioned about, so the guidelines we are discussing, the terminology we use in WHO, clinical practice and public health guidelines, they actually cover both areas that you had in mind. So all those areas, the system-related guidance as well as clinical guidance is produced. But then some of the, for example, nursing guidelines that colleagues were referring to are not guidelines, are protocols for practice. So we are not covering those protocols. Those protocols have different methodology. They usually rely on the just to sort out where we are and how we take it forward. But in terms of the process, I mean, Dr. Hussain, you referred to the issues of the 4 areas, and you mentioned about the structures and also the overlap between the programs of different areas and the committees that have been established under the leadership of His Excellency. The point is, when we, from WHO point of view, when we have a national program, and the national program oversees all of those processes, so different roles would have the role that they play. But when a guideline becomes a national guideline, then it is a guideline for everyone. So that's why all the stakeholders should be involved. That's why the committee membership includes all of those. So in a way, you have different players, but the players, they all join in the same role. And when a national guideline comes in, then the national guideline for everyone to be followed, whether it's university hospital, whether it's a police hospital, whether it's the public sector or private sector. So the limits of theirs are obviously known. In terms of implementation and cost issues, what I want to assure is that in the last few days and also last November workshops, all of them have been addressed. These are really, really important issues. And lastly, Dr. Naim, I want, so these points. Lastly, I mean, another point that Dr. Lataif mentioned, the issues of the international classification of diseases of WHO. So we have a new version, ICD-11, that is now out from 2021. I wanted to congratulate Egypt, because Egypt is actually one of the pioneering countries globally to implement ICD-11. And also, I mean, our region is actually ahead of all other regions, and Egypt is actually taking that much more further. And I know this is one of the agenda that His Excellency is following, its implementation and also WR, and we are also looking to support the country so that that standard is also implemented quicker and in a better way. Yeah, thank you.
Thank you very much, Dr. Arash. Sorry that I had to, but yes, we are doing the ICD-11 and it's being intensified under His Excellency leadership. One of the examples that Dr. Sharif gave was on the COVID-19 and how Egypt actually had the leadership to have a steering committee and implement. So we do have a success story in Egypt. And that's why Dr. Arash said that Egypt experience will be presented in October. And what we are doing now, the mechanisms, the approach, the adaptation, the safety, the strategy. The first day I mentioned about the human rights strategy. So under human rights strategy that Egypt has, we are trying to promote that the clinical guidelines is actually saving lives, saving persons, but also protect practitioners. So at this stage, I want to give the floor to the last speaker. Please be short, and then His Excellency is taking the floor.
يمكن أعرفكم بنفسي. أنا دكتور رضا حسين كامل، أنا أستاذ أنف وأذن وحنجرة في القصر العيني، وكان لي الشرف إن أنا أكون مقرر اللجنة بتاعة اللي هي جايد لاينز في المجلس الأعلى للمستشفيات الجامعية مع دكتور حسام عبد الغفار. وطبعا كان حظنا جميل جدا جدا إن الدكتور خالد عبد الغفار كان هو رئيس يعني وزير التعليم العالي، وهو كون اللجنه بتاعه اللي هي الجايد لاين. فالجايد لاين اتعملت قبل كده اهوت واحنا ماشيين فيها. احنا على مدى ال6 سنين اللي فاتت دي في مجال الانف والاذن والحنجره والسمعيات والتخاطب اشتغلنا في الجايد لاين من زمان، وابتدينا نعمل حاجه اسمها ادوبشن. فعلا احنا سمعنا الكلام ده جميل جدا. اللي حضروا الاربع ايام دول فرصه جميله ان يدركوا حاجه مهمه جدا. تادوبت سامثينج جميل، بس لقينا ان اللي احنا بناخده ده من بره ونحطه عندنا مختلف تماما، مش عارفين نطبقه. لا الدكتور المصري مؤهل لهذا الكلام تدريبه، ولا المؤسسات المصريه عندها الامكانيات دي، ولا الادويه دهيت، ولا المريض المصري بتاعنا نفسه حتى عنده الكالتشر بتاع تقبل هذا الكلام. كان لازم احنا فكرنا وقرينا، وفعلا كان يمكن الجايد لاين الاساسي بتاعنا هو WHO، ان احنا ذاكرنا الكلام ده قبل ما انتوا كتر خيركم جيتوا عندنا على مدى ال6 سنين اللي فاتوا، وعملنا بنفس البروتوكول تقريبا بالظبط. فاحنا فرحانين جدا. يمكن اللي شاف اللي هو البرودكت دوت يمكن منتج ل 29 توبيك من الانف والاذن والحنجره والسمعيات والتخاطب. كان لنا شرف ان احنا نشتغل تحت فعلا نظاره المجلس الاعلى للمستشفيات التعليميه، وزاره التعليم العالي. بس كان عندنا رؤيه جميله جدا ان احنا كنا على مدى نقول 30 او 35 سنه اشتغلنا في مجال المؤتمرات حاجه المريض المصري في كل مصر، وبالتالي اشترك في نقول الجزء الاول، لان احنا حاليا الحمد لله وي ار ببلشنج الجزء الثاني ل 29 موضوع برضه بالصدفه: انف، اذن، حنجره، سمعيات، تخاطب. اللي عاوز اقوله ان كونكلوجن، اشتغلنا مع بعض 254 استشاري، استاذ جامعه، اكاديميه عسكريه، اكاديميه الشرطه، تامين صحي، المؤسسه العلاجيه، المستشفيات التعليميه، كل المؤسسات المصريه كانوا انكلودد في الجزء الاول ده. 200 مكتوبين اساميهم وكل المؤسسات 254. مشينا بنفس الكلام ده بالظبط. جبنا كل الانترناشونال جايد لاينز، اخترنا واحد منهم، عملنا له نوع من انواع الادابتيشن باسمبلي بورد جميل جدا جدا من 5 من الاساتذه او الاستشاريين، وعملنا له نوع من انواع الجريدنج ب 45 واحد في كل توبيك، وبعدين عملنا له ريفيوينج ب3 نقول اللي هم الاثوريتي بتوع التوبيك. انا مش عاوز اقول حاجه غير ان احنا في مصر كنا اوير وفرحانين بيكم جدا كنقول منظمه الصحه العالميه، ان احنا فعلا كتر خيركم تيجوا تساعدونا بقى في بقيه التخصصات. وطبعا بشكر الدكتور خالد شكر شديد جدا جدا، لانه فعلا هو اللي زقنا ان احنا نبتدي نعمل لجنه ونزق فيها. واجمل حاجه بقى كنا احنا عاوزين فعلا نطبق هذا الكلام تو ديسيمينيت وامبلمنت اند اوديت وانتو فعلا ايفالويت. هل يا ترى احنا نجحنا؟ احنا دلوقتي في مرحله هل يا ترى احنا كل مؤتمر انف، اذن، حنجره، سمعيات، تخاطب حقيقي بنقول كل جايد لاينز. طب يا ترى احنا نجحنا تو امبلمنت هذا الكلام؟ ده اللي احنا في الايه في المرحله بتاعته. انا بس اخيرا بشكر كل زمايلي اللي هم اشتركوا معايا في الموضوع ده. 254 واحد في الجزء الاول و310 نقول في الجزء الثاني. فشكرا ليكم ودايما بخير. يمكن الدكتور بقى لطيف هو اللي معانا، هو طبعا زميل كفاح بقى في نقول اللي هي الترقيات، لكن ان شاء الله يكون زميل كفاح ان شاء الله برضه في
شكرا جزيلا دكتور، تجربة رائعة. في إذا كنت أقول معالي الدكتور خالد إن في هالقاعة كل شخص عنده تجربة. أنا لفيت وهنا على الطاولة الأولى تكلمنا في عن نفرولوجي، في عن ENT، لفينا على كلهم وفعلا في تجارب ناجحة وناجعة. حاليا اللي أنا أعرف توجيه معالي الدكتور خالد لنا احنا نعمل معا على أساس أن نجيب كل هالتجارب في بوتقة واحدة، كل التجارب في بوتقة، ففي تجارب وفي نجاحات وإن شاء الله بنبني عليها. معاليك الحين توجيهاتك.
صباح الخير على حضراتكم. والحقيقة أنا يعني مستمتع جدا بالحديث وبالمناقشات، ويعني أنا أسعد واحد لأن بالنسبة لي وجود guidelines أو Egyptian National Guidelines، سواء بقى هي clinical guidelines ولا هي standards، أيا كان التسميات، ده بالنسبة لي كمسؤول يخليني أبقى حاسس باطمئنان إن يبقى في عندنا طريقة نقدر إن احنا نتبناها من أسوان لإسكندرية ومن العريش لمرسى مطروح، لأن اللي بيحصل حقيقة إن كل واحد بيشتغل بالطريقة اللي هو شايفها، واللي بيضر في هذا الموضوع هو المريض وهو البلد زي ما الدكتور شريف قال. كل المداخلات قيمة جدا، لكن allow me at the beginning to express my gratitude and appreciation first to دكتورة نعيمة القصير، الحقيقة the WHO representative and in Egypt and a mission WHO and her team for this important collaboration and the commitment and the helpful spirit that I see along the years and the valuable work for all attendees, Dr. Arash and Dr. Paul and Dr. Nathan and Dr. Edith and Dr. Mehnaz and Dr. Malika. I think all of them, they have done a great job during the past few days in bringing this important session, this important technical workshop into reality. I agree with you. I remember 6 months ago, maybe during my meeting with the Director General, Dr. Tedros, I asked him that we want the help of the WHO for this important event, and I think he took it from there, and he was generous enough to ask the team to come and start doing that. And I also have to thank Dr. Mohammed Fauzi and his team for taking this into consideration and taking the responsibility of this important program. Important as a top priority for the Ministry of Health, not just because of the huge impact that we all expect to gain from this important step as regards to updating the clinical guidelines, if this guidelines is already available, because I'm sure that we do have a lot of guidelines already there, and we need to work on it and take it from evidence to policy, as you just mentioned. And the most important part is the difference between adoption and adaptation, because a lot of you talked about, can we implement clinical guidelines that is applicable in the United States, for instance? Maybe it's different for our culture, maybe it's different for our patient, maybe and definitely it's different from our capabilities and our resources. So the important thing is to implement something that we can afford to practice. And that's the beauty about this important workshop, with all these stakeholders coming, and I can see them in the audience. So it is important for all of us to ensure patient safety, as Sharif was saying, and also improving the health outcome and cost containment or the cost recovery, and that's also another important issue that we have to focus on. I think in order to achieve that, implementation is a great challenge. Dr. Hussein mentioned about who will lead the process. Now we have a legislation. We cannot talk more about that. We have the Egyptian Health Council. It's part of this mandate is to be responsible of bringing out this clinical guidelines for all specialties. But who will do that? Societies can do that, universities can do that, Ministry of Health can do that. But at the end of the day, he has to be responsible of adopting the clinical guidelines that will be applicable for all health sectors in Egypt. لكن ممكن تتعمل من جمعية كبيرة، وده حصل كتير، ممكن تتعمل من جامعات، ممكن تتعمل من مستشفيات تعليمية، ممكن تتعمل من الجهات كلها اللي احنا قلناها. So it doesn't make any difference who will do that. As Dr. Hussein was just mentioning about the ENT project and the ENT guidelines, that more than 250 participants worked on that from different sectors. But at the end, this ENT guidelines should be presented to the Egyptian Medical Council to be reviewed by another committee. And this committee will add or improve or adopt this as to be the national Egyptian guidelines for ENT. From that part, he will send it officially to the Ministry of Health. He will send it immediately, officially to the university hospitals and all other sectors, asking them, this is our ENT guidelines that would need to be implemented in Egypt. So we will take it from there. We'll do training for our staff. We will take this to the diplomas, to the, all the board exams. And so, because the most important thing is to train people how to do that. You can have the best, perfect guidelines ever, but nobody's practiced to work with it. And most importantly also is the liability. Because if you have a guidelines, then you can have a liability that if somebody didn't follow these guidelines, and if something happened to the patient or something happened to the organization, and it has to go to the court. So the court has to ask a group of experts to evaluate if this was second or due to certain national guidelines that he followed, or he did that on his own practice experience. So it's not just for patient safety, but also for liability that we have to work with. So I think rapid adaptation is important, and using international guidelines as a reference is mandatory. Improving the quality of clinical care and also equity. We don't want poor patient from Aswan or from Luxor or from Sohag to get treatment less than somebody else in a private hospital in Cairo or in Alexandria. That's unfair. That's not equity. But equity means that we all have to follow a standard diagnostic procedure or a clinical treatment procedure. So the standard decreases practice variability. If you have standards, then there won't be a variability between practice, or at least it will be as minimum as possible. And that certainly will be reflected on patient safety and medical responsibility. So medical legal protections of the healthcare professions, as I said, as regards to liability is important, and the economic burden of diseases and also interventions also is very important. And since we're going to universal health insurance, and we have to have some guidelines that we all follow across the country. Again, I would like to thank Dr. Naeem and her team from WHO, from the MRO, from the headquarters, Dr. Mohammed Fawzi Soda and the higher committee and the respectable members that worked with you, all respectable professors and participants that gave from their time and joined us during the last few days in order to disseminate this important information about the Egyptian guidelines. And Dr. Lutaif, you have a lot of challenge in front of you, and I'm sure that we are going all to help you in doing that, and certainly the WHO won't spare time and won't spare effort to work with you in that field and in other fields. I know that your mandate is diversity, and the diversity of the Egyptian Health Council is huge, and you need to start working as soon as possible for bringing that into reality. We don't have much time. I think if we need to work fast, and you need to have a time bound for that process, I believe before the end of this year, and we are still in February, we should have something concrete, revised, adopted you know, everybody started to train and already implemented. And you know that we talked about in the middle of the year that we should start training our personnel in different areas. And that, again, thank you all for being here and for helping us from the WHO and from our team and my members and colleagues from the Ministry of Health. And I wish you a very successful meeting, and I'm sure that that won't be the last one, and there's a lot other to come. And please, thank you for Dr. Naima for helping in this important regard. Thank you all. Bye-bye.
دكتورة نعيم اتفضلي يا فندم. السادة الخبراء اتفضلوا معايا.
هي ما تجيبش مش هرجعها لكم على طول. انا قلت لهم حتى في التقرير والله العظيم كويس خلاص وقفت فيه. لو كان فيها الطير لو كان فيها العيال
Very nice to meet you.
Thank you.
Very nice.
اتفضل دكتور محمد. أيمن. أيمن. أيوة تمام كده فهمت. تمام دكتور. أيمن. شكرا فندم. السلام عليكم.
So for the second half of the day, بعد إذنكم طبعا, for the second half of the day, there's going to be a little bit of a change around the schedule so that we keep the time and we end inshallah at 3 o'clock as planned urgently to accommodate the intervention from His Excellency. So at the end of the day, we will be receiving our certificates. And for now, we will start with Dr. Paul Garner. Sir?
One of the things that we've talked about is about adaptation of guidelines and putting them in using existing systematic reviews and putting them into a national context. So I just wanted to give the final example, which is the COVID guidelines from India. And this is their website, and it's really just because His Excellency is talking about rapid turnaround times, using this approach, obviously, in India was done very quickly. And they used a full-grade process. In fact, the people that were involved in establishing it drew on the TB, extrapulmonary TB guidance methods, and some of the people in India were exactly the same. So, and this is their COVID guidelines, the front page of this website, and there's a diagram here which, can people see it all right? I can't, yeah, is it, so they put the interventions down this side, and this is the summary across all the different systematic reviews and evidence to decision making that they've taken. And for example, the ivermectin review that they did early on, within a week of them producing this guideline, the national government stopped recommending ivermectin. And if you click on ivermectin, this is a standardized format that we established. And the thing with COVID is it's stratified by disease severity. But if you look here, they start off with, we do not recommend COVID. That is the recommendation at the top line of it. And then they define which sorts of illness, what they mean by moderate and severe and critical. But underneath this, they have justification, which is a narrative of the evidence. They then have an evidence summary, which we've been talking about. They put in, and you know what this is now, isn't it? Summary findings table, right? Yeah. So they have a summary of findings table here. They have the methods of the review that you can click open, the results, and then the forest plots, and then the evidence to decision making. They've chopped this down a little bit, but you recognize that from yesterday. Yep. So that's there. Bang! Evidence to decision. You can see it there, and they put a little bit of narrative behind each of it, and then they put all of the other headings down there, the implementation decisions and so forth. So there's no implementation issues with ivermectin because they don't recommend it. Now, some of them, like I don't know, corticosteroids. I mean, what I'm trying to in the prone positioning, they initially used observational studies and systemic corticosteroids, as you can see here, in the mild and moderate, it's not recommended, and in the severe and critical, it is. So each of those was considered separately. So where's it gone now? There. So we do not recommend in non-severe, this was happening quite a lot in India, steroids were being slopped around all over the place, strong recommendation. We recommend its use in hypoxic patients with COVID illness. So all I'm trying to show you is how this group standardized this and displayed it online in this way. And I tell you, all of these were updated once or twice, certainly once. Most of these interventions, unless they dispensed with them, were updated after a couple of months when some new trials came out. And we can, it might be that some people from India just provide some outline of what they did. They haven't written it up yet. They're still sort of updating it. But they first went through all the existing guidelines and assessed what they did. They then looked at the existing systematic reviews, and almost always they redid the systematic reviews. It was not too hard because there weren't many trials coming out, and there was also a lot of debate on how to interpret these trials in different settings, and the outcomes were muddled and so on. And they really did need to go back to the original trials, and they fought them through. There'd be 2 to 3 hours until people had internalized the evidence base, the grade tables, agreed with it, and went on to the recommendations. So this is a good example of national decision making in real time, with revisiting the evidence and doing it quite quickly and putting it all together on in a standard format on a web page that's accessible to all. So it might be worth looking at that, or we can certainly put you in touch with how it was organized. And it was all done online as well, so that the conference calls were mostly clinicians in India. 1 or 2 people from outside were involved. They had a methodologist, as in our goldfish bowl yesterday, exactly the same structure, methodologist, systematic review team. The systematic review team were young doctors that were being supervised to do these reviews. It was a very dynamic process, but it's possible to do it really quite quickly. That's all I wanted to show. Thank you. So I'm over to, I don't know who now.
Thank you, Paul. So now we will have Dr. Nason for the session on guideline, some further consideration about guidelines, rapid guidelines, living guidelines. Thank you.
Thank you very much. So this is a very brief update of some of the new developments that we are taking into consideration at WHO headquarters. So it's to give you a brief snapshot of what is new in guideline development. You already have a lot to consider here, and so this is hopefully not going to be additional work for you. It's rather to let you know what we're thinking about in WHO for future development. So please don't imagine that you need to be doing all of this tomorrow. It is something to consider for further down the line. So I'm going to talk about rapid guidelines, living guidelines, smart guidelines, and brief consideration on updating of guidelines. So rapid, here's what we have. We have, I hope you can read this. We have 5 different sorts of guidelines, if you like, that are developed by WHO headquarters. Standard guidelines, they can be large documents, several hundred pages. They may take up to 2 years to develop from the start of the idea to the final guideline being developed. And they last for up to 5 years, so they're updated every 5 years. Then consolidated guidelines are when you have different guidelines on different disease areas. You may have a guideline on treatment, a guideline on prevention, a guideline on diagnostics, and then you put them all together and consolidate. There's no new evidence review, there's no new process required, it's just putting it all together to make it easier to access. Living guidelines is something that is talked about a lot at the moment. It's a new innovation. And the idea of living guidelines is precisely as the title suggests. It's that the guidelines are very, very regularly updated as soon as important new evidence becomes available, sufficiently important evidence that you need to think about changing the recommendation. And I'll give an example of that in a moment. And then here we have rapid advice guidelines. They take 3 to 6 months to develop. They use rapid review processes, so shorter than the full systematic review. They tend to be focused. An example might be the wearing of masks for prevention of SARS-CoV-2. And they include new recommendations. They have a short shelf life because they've been developed rapidly, so the intention is to do a fuller version later down the line, but you're wanting to give end users very quick information to be able to respond to an urgent, unmet need. And then you have emergency interim guidelines. These are some guidelines that WHO produced early on in the pandemic. They took days, and they had very, very quick reviews with some expert opinion, because there was not time to do a full systematic review. They issue new recommendations, but they're not meant, but like rapid guidelines, they're not meant to last a long time, because the methods used have been abbreviated, so you need at some point to go back and do the full process. But this is because there's an unmet emergency health need, actors need to know what to do, and you need to be able to say something quickly. So that's rapid guidelines and emergency guidelines. Living guidelines are, as the name suggests, you keep the document alive. They're talked about a lot at the moment because they're seen as a way to be more efficient. But in my view, living guidelines are exceptional. It's very rare that you have a situation where the evidence is changing so continuously that the recommendations become rapidly out of date and need updating very regularly. The therapeutics for COVID is a good example, where clinical trials were reporting results every month, and the organizations like the World Health Organization needed to be able to issue guidance, to have a recommendation on how to use the new therapeutics, so that countries could understand whether to consider using the drug or not. But there aren't many other health areas. I'm sure you would agree, there are, in your disease areas, it's very rare that evidence, really good evidence, is being issued at such a frequent basis. So whereas with normal guidelines in WHO, it can take 1 to 2 years to develop the guideline, it's a very extended process. With the COVID therapeutics, we managed to put out a recommendation on remdesivir within 36 days of the trial being reported. So it's a rare situation, but it's to give you an example that when there's will and resources, you can produce guidelines within a matter of weeks, and it's an exceptional situation, but it does exist. Smart guidelines are really, this is a technological area where you're trying to digitize the guideline process as much as possible. You may have several different disease guidelines that have a common recommendation across the different guidelines. And what smart guidelines try to support is, if one guideline over here changes its recommendation to say, don't use this drug, use that drug instead, it's immediately updated across all the guidelines. You don't need to, it's to avoid a situation where you have 3 different guidelines saying 3 different things about the same disease area. So it's trying to speed up and harmonize what is being recommended across all the guideline areas. And you can imagine this can happen on a web-based version of a guideline, or through an app that can be on a phone or a tablet. But it's to ensure that once you update something, it's updated rapidly across the board. So WHO is working on this as well. And then finally, to note the challenge of updating guidelines. You have a guideline, you've just published it, 6 months have gone by. The committee asks the question, well, how long can this guideline be relevant for? You can update guidelines too soon. You can set up the committee, do a systematic review, convene experts, but actually nothing's changed. The new evidence hasn't yet become available when you've sat down to do the process. So that's a waste of resources and it's a waste of money. On the other hand, you can be too late. You can have a whole number of important trials finishing, lots of evidence being produced, and it's only now that you sit down and do the systematic review and convene the experts. So this is a problem as well, because you could say that this guideline is out of date and making suboptimal recommendations, and patients are not getting the best care because this new evidence has not been looked at. So updating guidelines is a balance between ensuring that you're not doing it too quickly and you're not doing it too late. And Paul Garner has been among a number of people who have thought about the timing of updating systematic reviews and the timing of updating guidelines. There is no magic answer. It's simply important to be scoping the area, keep your eye on the field, and then when the time is right, start the engine again. So that's all I wanted to say. It was simply to make you aware of what's happening at WHO. You may not need to integrate all of this tomorrow here in your country, but we're very happy to share tools and resources on any aspects that may be of interest. Yes?
Is it a must to put a date for the update of every guideline at the end of the guideline or not?
Is it a must to
put a date for the updating this guideline within 2 years, within 3 years? Because, as you said, it may be too early, too late, so what we can do?
So I think you can only really, so with the rapid guidelines and the emergency guidelines where you used shortcut processes, I think it's important to make a statement that these guidelines are interim and that they will be updated as soon as important new evidence becomes available. For the more standard guidelines, you can make a promise. You can say these guidelines will be updated within the next 3 years, but you cannot be precise because you cannot know. It's very difficult to know when the new evidence will become available. That when important new evidence arises, yes. But I would suggest avoiding making promises that don't get kept.
I mean, this is really important. Any guideline needs update plan, any guideline. So any guideline should think about it, etc. Especially when you identify, for example, the research gaps or areas. You say, I'm actually looking for any new research that might help me here. So that becomes your thing. The concept of, moving to living guideline, etc., is a complex process. But as long as you actually think ahead and plan for that, and so perhaps, for example, I don't know, as part of the national agenda, it could be that the related committees might meet every year and just discuss certain things without committing that they will do things. And also you open a way that clinicians would write to you saying that, well, we are seeing a new problem here or a new trial has come, so that you are informed, and then you feed that into the process of your priority setting. So in a way, as Nelson said, it's easier to say fancy things and not doing them, which is damaging to the reputation. It's better to promise the things that are possible and then attach to them. And if you do more, then everybody will be happier, rather than sort of complaining to you.
I would suggest that you need 2 processes. One is a monitoring of the field, and specialists in the field would tend to monitor the field anyway for big, important trials that may overturn or massively change the strength of the recommendation. Partly because if you don't take those on board quite quickly, the guideline itself loses credibility. So you need some kind of monitoring of the field somehow that is light touch, but looking for things that might overturn it. And then periodically, you do need to go back to the guidance and look at the different recommendations through the whole set of the guidance and say, have we got the right questions? Has this intervention been overtaken by another one? Is there some new diagnostics here that are changing this recommendation? So a little bit more of a considered approach where you then might choose to update 3 or 4 of the recommendations in a particular way. There's no point in where things are clearly established going through the whole process again. It's exhausting doing the review and so forth. But I would suggest that that's a pragmatic approach.
I'll give one quick example. The last guideline I developed was on managing cryptococcal disease. It's an AIDS-related meningitis, an HIV-related meningitis. And we knew about the end date of the trial 1 year in advance. So we kept in touch with the investigators it was a trial for better treatment. And the moment the trial was concluded, the results were shared with us, and the new drug was a lot better than the old drug. So even though the information was not publicly available, we started to form the groups and put the guideline panel together. The moment the information was published, the guideline was published 1 week afterwards. So you can't always do that, but sometimes you can move quickly. So I think that's it for this What's New session. Who can I hand to now? Or are we still preparing?
Thank you so much. One of the things that we had planned to do is to go through some of the available documents and references that are related to the guidelines. Especially, there have been some guidelines that have been revised and done by nationals with the assistance of WHO country office staff. Dr. Randa, unfortunately, is not with us. A lot of the non-communicable disease-related guidelines, she wanted to talk about those. But for the next few minutes, if I can invite my colleague, Dr. Liz, for 5 minutes, please, Liz, to talk to us about the AWARE Antibiotic Handbook, which relates to many of the infectious disease guidelines. Thank you, Liz.
Great, thanks. I've got a big voice, so can everybody hear me? Okay, great. I'm going to talk about an antibiotic book that was launched in November this year by WHO. And you may say, why do we need to have basically it's a book of syndromes, the commonest infectious syndromes in humans and adults. And why do we need it? Well, infections, huge burden of disease. It's really important. About 13 million people dying globally. And also, in primary and secondary care, we know that it's a very large proportion of the workload. I'm interested in antibiotic resistance and preventing it. And we know that in most countries, and I think Egypt's the same, qualifying doctors are very, very unconfident about using antibiotics. And at least half the prescriptions for antibiotics are probably inappropriate. So this is something that is a real important public health interest, and so we develop a book on it. And this is just the process of it, and this should be very familiar to most of you now as to how we do it. The combination of synthesizing systematically existing guidelines, the scientific literature, and then having a very, very broad expert consultation to try and get something. Now, it's a global guideline. It should be adapted locally but it's got to be adapted locally on the basis of really, really good evidence of what's going on that is representative of the population. So I'm doing this very quickly because we're in a hurry, but For a lot of the conditions, antibiotics are not indicated. So the first message that we give is for example, for earache, for sore throats, antibiotics are not indicated. And this is useful because it helps the clinician to do the right thing. We know patients want it, but you can say, actually, the WHO guidance is, in most cases, it's not indicated. Then it gives you the first line treatment, the second line treatment, and it helps you think through how you diagnose, what the dose is, the duration, and all of that. And guidelines are great, but how do we get it to be used and adapted? The actual book is 600 pages, and most clinicians are not going to use that. So what we have is quite nice infographics that you can see in 1 or 2 pages all the key information. And I think this is going to be really important. You can actually print it out and put it up in the ward in primary care or whatever. But the other thing that I think will be a game changer is that it has an associated app so that, you know, the prescriber has got it in their pocket. When you've got a patient you don't quite know what to do, it gives you all the details of dose, duration, and everything else. So that's freely available online. Just Google the antibiotic book. So many thanks, and I hope that was short enough, but we would love to talk more, talk about how it can be used and how it can be incorporated in systems and training. Thanks a lot.
Many thanks, Liz. That was very efficient and very well presented. In a way, it's also linked to the whole discussion that we are having. As you can see, the packages that Liz was demonstrating to us was feeding from different resources from WHO. It wasn't just the guidelines, but also, for example, essential medicines lead, the program. The same happens in the national level as well. But then the issue is not if you have a document, but you don't follow it with the other documents that people really need, or other approaches, other implementation strategies that help you to take that forward. So then your work is not successful. As we had mentioned in the workshop several times by several of you, but we heard also in the presence of His Excellency Professor Khaled that several senior colleagues raised that issue as a main requirement. And that's the whole intention of doing it. So these examples also occur at the national level at many levels. So what I'm going to do is just, this slide said I didn't want to change it because we discussed that in details in with some of you when we met downtown last November in the workshop. That is recorded, is available, people can refer to it. What I wanted to focus on is just this slide in terms of interventions that are needed for implementation of any recommendation that you may have. So now we are focused on the guideline recommendation. When we talk of implementation considerations, we are not talking of writing a textbook for a guideline, say that, oh, the finance should be like this, the payment should be like, no, that's not like that. The main issues that come to your mind, thinking that if I send this guideline to Qasr Al-Aini Hospital and I'm expecting people to implement it, how can they do that? If my guideline is going to go to the Port Said Clinic primary care and I'm expecting the physician there to implement the recommendation of the guideline, what is needed for them? So those practical considerations that is in the back of our mind, but sometimes we may forget them and we may not consider them. And also the fact that you have multidisciplinary team people within your program sitting together, each one of them bringing their own criteria, their own considerations, then people can also inform each other. A recommendation that looks very easy for me, another person says, oh, no, it's not that easy because of these challenges. And then you say, okay, how can we make it easy to be followed? And you make these discussions explicit after you finalize your recommendations. You remember when we are discussing evidence to decision framework and we are bringing all those values, consideration, criteria together, we are actually thinking of implementation and challenges at the same time. So those are your notes, those are your understanding. But when you agreed on the recommendation, what that should be done, what that is best for the patients, for the public, for the society to be done, then that's the time you also go back again. Okay, now I'm telling people to do this, but then imagine I'm telling myself to do it. What I need to be done so that I can do it. Do I need any help? Do I need any changes? Do I need any resources? And then you put only the serious ones, the ones that really matter, the ones that are important. The challenge we always have, and the reason this slide is important and I'm putting it here, is that usually when in medical arena, when we discuss the issues of implementation, we focus on certain things. First of all, on finance, in terms of the resources as well as the payment. So in the last 3 days, none of you mentioned the issue of paying doctors or paying nurses as a barrier or consideration. But we know that's a real issue. You can't just, and certain good recommendations may not be followed just because we haven't thought of the financial incentive. And as soon as it goes out of the sort of the committee, that becomes a concern for some people, especially if the recommendation may affect the earning of people, may reduce the earning or may increase the earning or may change the balance of earning. So those part of it, that's usually, teams usually think about that considerably. The other thing that we usually focus is issues of education, continuous medical education. These things we don't forget most of the time. But there are many other interventions that we can select from. And if you try to list all of them and say more of this, you are not helping people either. Then you need to think of what would be the best approach for a given recommendation, what can help, and then you link that also to an audit evaluation criteria. So for certain programs, a reminder is good. Then you think of what would be the best reminder. What would be the reminder approach that is needed? Reminder to whom? Is it better to remind doctor when the patient comes to the clinic? Or is it better to remind the patient to be able to follow? Or is it better to remind the nurse to do that? And if any one of them, your answer is yes, then how is best to do it? Nowadays, I mean, most of the time should be done on the computer system, but we know that it's not available always. There are many doctors that will tell you, well, I have a computerized word system. Everything is in the computer. The reality, the doctor doesn't even touch the computer in the same word. They just say people, so enter that and relying on other people to do that. So if you put any reminder for the doctor on the computer, that's not going to help. Because that would be seen by someone else. So then you need to think of how the real practice is happening, how people are interacting. So when you consider those, and the reason I'm referring to that presentation before is that provides you the package of thinking the process going ahead. The other thing you can refer back to is the issue of the discussion we had earlier in this workshop. Again, when we were talking about evidence to decision approach framework and how to bring evidence to the level of the recommendation that we have, we had several examples. I had a few examples from real guidelines. Nathan and Paul also, they gave real examples. And in all of those examples, there were implementation considerations also considered. So they were not packaged as part of the package we are having here, but they are actually everywhere. And that's how it is. So for example, a question here. So maybe given that we all just listened to Liz a few minutes ago, so Liz, what would be the main recommendation you would like to see to be implemented in Egypt? So one recommendation, please.
Well, for flu, you do not need an antibiotic, paracetamol or brufen.
And we all know how difficult it is to implement this single recommendation. So then, you are the panel, this is the recommendation in front of you. What are the implementation challenges? What would you do? There are a few things I can just tell you that you would tell me. You would say educate the public, educate doctors, put pamphlet, but all of these are already done. Okay? What else can be done? What can you think of as an implementation process? So maybe 3-4 colleagues can mention.
Performance-oriented audit and feedback.
Okay, so how do you do that? Explain.
I will make committees for evaluation, continuous evaluation for continuous improvement, and perform or put KPIs to know if the guidelines is implemented rightly or not, and if this adapted or adopted guidelines is fitting for our practice or not.
Okay, so let me challenge you. So I'm a clinician. I have an office in Doi, private office, and patients coming. I don't know how you can see how I prescribe. Imagine that you can see it through the, for example, insurance records or whatever, and you come back to me telling me, oh, you have too many people prescribed. And then I say, well, they did not meet your guideline criteria. I was suspicious of microbial infection, not flu. How would you address that? So because if you tell me, oh, I'm going to check every patient, then I would say you will not be able to do that because too costly, too time consuming, you do not have resources. You better to use your resources in another way. So in a way, when you think of a sort of process of using these, you need to also think of if you want to apply your implementation approach, is it that possible or not? Is that easy? You may say, well, my focus was on the hospital level in, let's say, infectious disease departments. Then I would say, yes, what you said is totally possible, but probably in Egypt, 95% of mistreatment of flu is happening outside those places. So again, you have something useful to do, but you are not addressing the main problem that is there. So one here, and then we go to ENT colleagues sitting in the back.
In my opinion, I would start at two levels. The first level would be physicians and decision makers. That would be with competence orientation and performance orientation. Then the next step would be social influence. This is a very important part of the dissemination of a message. Okay. Okay. At the level of physicians, I will start with CME and messages and protocols. Maybe courses or meetings. Okay, I will start. Okay. Okay, for example, community-acquired pneumonia. I will start with a conference with reliable physicians, multidisciplinary, of course, and we will start putting our guidelines or protocol. Then we will make at a larger level, we will make a conference, for example, with workshops as courses in parallel. So we got some education in this. Then at the second level, at the hospital level, we will start implementing our recommendations, and we will do some audit and feedback so that this can be applied on this institute. Okay, and then the mass.
Many thanks. But just bear in mind, so if I, for example, wanted to go a bit further with the recommendation that Liz was referring to. For example, one other challenge I see in Egypt myself, and also in the region, is not just antibiotic for flu. It's actually the third generation antibiotics for flu. So again, yeah, so how are you going to address all the, so maybe we get 3, 4, so I have some beautiful hands ready. So one here, one there, and okay, 5. Let's stick to 6, okay.
First of all, if we are addressing doctors, we are addressing the wrong community about that. I have one.
That's all right. So you go ahead and
okay. If we keep addressing the doctors are not a problem in the treatment of flu. We are addressing the wrong community. Actually, more than 99% of the flu patients are treated by over-the-shelf antibiotics in the pharmacies. So it is basically, we want to talk to the pharmacist, but the pharmacist wants to sell. He has a financial conflict of interest. So it's very easy to refer to the policymaker, please restrict the on-counter, over-the-counter selling of antibiotics and make it only through prescriptions. If we did this, basic step, we cut off more than 80% of the problem.
So I think that was really good point. So in a way, so we know use of medicine is a doctor-patient relationship, but the reality is that we know also in Egypt and in some countries of the region, but I mean in Egypt I see it more than others. So in Egypt you can actually call someone and they bring antibiotic to your home. You don't even need to go to the pharmacy. So if you have this, even if your doctors are the best educated, you probably don't solve the main problem.
Thank you for your answer, because this is exactly what I was going to say. Well, I'm an ENT professor, and of course, I would say that 99% of my patients who have a flu, just to make things basic, which is a viral infection, they already have taken an antibiotic before coming and see me. And why? Because buying an antibiotic is like buying a sandwich. So the first thing I think should be to restrict the selling of antibiotics to be only with a prescription. This is the most important thing to do. Now, education of the doctors would be maybe easier to do, but first of all, we need to educate the public not to go and buy. I always tell them it's not a candy. You can take an antibiotic and it can cause a severe reaction, so please don't take antibiotics on your own. And actually, with the guidelines that we made, because I was responsible for the acute otitis media, you discussed it yesterday, I was referring to that point exactly. Please don't give antibiotics to anyone, even who has an acute otitis media, because most probably it's viral, and then we have to give the body the chance to recover by itself. 100 years ago, there were no antibiotics, and people used to heal. So this is very important.
Okay, very good. And then, I mean, just think of, I mean, we don't need to discuss all of that today. So I've got 3 more hands already in the queue. I mean, then everyone 30 seconds, and I don't reflect after you, so just we listen to you one after the other. But then think of, if you wanted only to focus on this recommendation, implementation consideration that was mentioned, which all of us, I think, probably no one, even the pharmacists in the room are not going to disagree. They will be concerned about the financing of their pharmacy, but they will not disagree about the importance of the program that we are discussing here. Just think of it, if you wanted to do only that one, what would be your challenge in reality? What changes need to happen? What program needs to be implemented? How to be followed? So I start from the back of the room and then we follow.
I have the same comment. But with a modification. Especially when we're talking about the antibiotic, not even from the pharmacy, not to be given because we have an issue with the doctors themselves. Also, they have the concept. Some of the doctors and a great amount of them, GPs and junior doctors, and even some seniors, are thinking to treat flu with antibiotic. So, if you want to restrict the population that we are giving them the message and we want to control them, we will forbid selling antibiotic in the pharmacies, in the outside pharmacy. We will restrict the antibiotics to the in-hospital pharmacy. So if we want to control them with a guideline, we can follow, and we have liability after this. But to survey all the pharmacies outside, it will be very, very, very difficult, okay?
I promise not to reflect in between, but I mean, just think of any of these considerations would have also other ramifications that we need to think at the same time.
Referring to what have we listened or what have heard, so we tried before conferences, audits, everything like this is a little bit more theoretical. You can start with as a campaign of the change you would like to do, but more practically to have on daily basis practice, to have a personnel who could be responsible about monitoring this. So to have, for example, a clinical pharmacist in your team is such more important to monitor this operation, and later on we can monitor it once again at the medical record of the patient.
Okay,
just not regarding the flu in it. Okay.
Not regarding the example of flu, but because it is not applied for everything, because maybe if I talk about the high cesarean section rate in Egypt, it's multifactorial and many interventions should be done. So we start with the training, we put the guidelines, train on the guideline, we have the Egyptian fellowship of the Egyptian pool, we can train through it, and the follow-up of training. And again, the most important to have those algorithms or the pocket manual, which be in the pocket of each junior doctor to be able to follow. We need to raise awareness, of course, of the community, and this is another very important issue. The nursing staff, and sometimes in certain important national problems, we may use incentives as well.
Shukran, please.
For flu, one item in over-shelf drugs in our homes is antibiotic. It is, may be prescribed with your friend as not physician. I have a flu. Take some antibiotics. So it is need media and awareness of the populations and people about abuse of antibiotics. Next step, next issue, post-operative antibiotic. We can't guarantee or have braveness to leave patient without antibiotic post-operative, because it is multidisciplinary team, infection control, paramedical, paramedical experience or paramedical follow strictly infection controls, and so you can't guarantee this. So no one can be brave to leave the patient post-operative without antibiotic. In our
which is the challenge that you have in the context that also affects the follow-up of the guideline. Okay, last person.
Thank you, Doctor. I believe that primarily we should increase the awareness of the physicians and the clinicians to the importance of use of the clinical practice guidelines and the adherence to these guidelines, because many clinicians or healthcare service providers as well see this as a burden. As you know, in the past, they used to have their experience, and the experience of the doctor is much more important than any other item. But now, by the use of the evidence-based medicine and these guidelines, and that the policy and the political leadership to increase the adherence of the physicians to the clinical practice guidelines, this is an important issue. But first, they should know and they should be aware of the importance of use these guidelines for the sake of themselves before the sake of the patient. So increase the awareness, it's very important.
Yeah, and I'm not going to do this. If I probably ask you here, saying that how many of you do not take antibiotic after you have flu symptoms, I would say there are very few of you who would raise hands. So, okay, very good. So let's do that. How many of you, when with flu symptoms, do not take antibiotics? That's about half. Yeah. I would say it's much better than the average in the society. Yeah. Okay, so as you can see, so we are not, the case we had, a guideline or a sort of a clear clinical practice recommendation, that even wasn't a surprise to us. We knew it. So a good guideline is actually the start of your journey rather than the end of your journey. So that's how to do it. It's like sort of, I don't know whether you have this culture in Egypt or not. So the New Year resolution. So you sort of, after New Year celebration, you say, well, I'm going to become much more, healthy eating, stop smoking, or whatever decision you make, running, putting aside my cigar, whatever I have as a plan. So that becomes your resolution. That's a good guidance you have. But you know that the guidance is actually nothing unless you manage to do it for a year, which is the main thing to be done. The other thing I want to refer to now is that, Malika, can you help me please, the adaptation guide, please? So because now we are getting to the sort of closing sessions. While Malika is doing that, so we listen to Liz very short. She referred to some WHO resources, but then the Mehnaz and Riham have also provided a sort of a compilation of WHO guidelines that could matter to Egypt. That will be made available to all of you, so you can refer to those guidelines that WHO has. You know, we are aware that not every WHO guideline is well distributed. So in a way, it's also part of your program. You can look at those and see which one of them better applies to your case. So go, I do it. Many thanks. So remember, we discussed the notion, what do we mean by adoption? And Professor Khaled also referred to that concept in his remarks today as well. The adoption, and then when we decide about adaptation, different scenarios, how we do it, and we know the issue of the main priority or the main engagement of this program in Egypt will be adaptation of guidelines that exist. For example, from WHO guidelines or another reputable body guidelines that is answering your PICO questions. So just before I hand over the microphone to colleagues, I think after this will be Naima, yes? Any other thing we have? No, we don't, okay. So before handing over to WR, so that she will discuss the next steps, and just wanted to bring all of us on the same page again. So let's say if we wanted, we had one session on priority setting. You remember the criteria for priority setting. I was talking to my esteemed colleagues, professors of ENT behind the guidelines of ENT that was referred to also in the morning. I mentioned, so within those guidelines that you have, which one of them are the most important priorities for you? Which one of them which topics are the most important thing that you think is a big challenge in Egypt today? If someone applies that guideline, actually health of people will be improved in a substantial way. So identify, so let's say we have those priority lists that, the plan is to have it within the next, maximum maybe 2-3 weeks. That list of priorities that will be the focus of the first batch of this program as an output. So we have the priority list. So today, let's say imaginary, if we were the guideline panel, we could more or less, or maybe not the guideline panel, behind the guideline panel in terms of the process, first step, we could actually work together, develop the main criteria of scope. So some discussion, obviously there is a paperwork behind it, some literature review has been done, but we would discuss the sort of, what are the main issues we want to cover, what are the main concerns that we have, what is the population group that we are addressing, level of care, will it be in a hospital problem, a specialist hospitals, whether that's a primary care issue, community care issue. So you identify all those issues that you have, and then maybe sort of a first glimpse of the question. The experience, the exercises we did the first couple of days of this workshop, so we could actually develop also some preliminary PICOs. Then the next thing we would do together, we could actually establish the guideline development team. Not by saying it includes Arash and Marian, but saying that it is someone from this specialty, someone from that specialty, someone from this profession, someone from that profession. For example, if it is an ENT guideline, if you are thinking of a panel that is 10 people or 15 people, you may need 2-3 ENT specialists from different parts of the country, different levels of care they are working. But then, for example, if it is an infectious disease issue, so definitely you need a sort of microbiologist perhaps, or infectious disease specialist. You may need pharmacists, you may need nurses. So you identify, you go through that. And then at least, so addressing the first questions in the preliminary approach of it is actually requires the attention of some able people that are focused on the topic for 2-3 hours. It's not a massive thing to do. It will be compiled, and then the next step would be to bring people on board. The main challenges becomes the sort of the technical work. While you've done these steps, and then so the letters from Dr. Fauzi will be sent to different societies. Dear lady, chair of the Society for Blood in Egypt, or dear sir, the dean of a school of medicine in this, so I want a nomination, I want this person to be released or whatever for this purpose or to be nominated. While you are doing that, the technical team behind the guideline will start doing this work. So they will search whether there is any existing guideline. They will look at what is the systematic review behind that guideline. They may do a quick assessment using Agri2 themselves already. So they do a quick assessment, they look at the evidence gap, they look at how it's going, they think about the original PICOs, do they need to be updated while they are searching? So they find a good guideline done by NICE, and then they say, well, NICE has 2 more PICOs. Do those 2 PICOs are helpful to Egypt as well? Are they a challenge Egypt or not? Or another guideline, so let's say cardiac, I mean, I saw one of your guidelines is adapted from a Japan guideline. So the Japanese guideline, they might have had a different wording for their PICO. They might have structured differently. You think, well, is that a better structure or not? Should I change or not? So you do all of those work in terms of early assessment, etc., while you are working for the panel to come. When the panel come, then the team will be technical team. I mean, the first meeting of the panel, so whatever time is. So I don't want to push it too much, but maybe, for example, in a month. So then people are invited for a half-a-day meeting that would give them ample time. Then you go again through the whole processes. These are the guidelines identified. This is the result. What do you think? How to take forward? And then the processes. And then basically you are in the middle of the business. That's how it goes. And then the issues of what needs to be done, updating evidence is one line here. Obviously, it's a challenge. It's a difficulty to be done. And then finalizing your recommendations. And then as we saw today, a simple recommendation, not all recommendations are that difficult to implement, but a single recommendation may need ample discussion about implementation aspects of it. So the recommendation is, another recommendation may not be like that. It could be sort of change the first line of treatment from this medicine to that medicine, and the other medicine is also included. Then you may focus on CME for that one, or sort of the guidance for doctors rather than to become considering the whole health system approach for resolving the issue you have at hand. I want to repeat again in this process, the issue of conflict of interest for the panel members and the team behind the is absolutely important. We saw some guidelines, they have actually direct funding from pharmaceutical companies. This happens, as I said, most of the guidelines globally are developed by support from pharma companies. We do not recommend the national guidelines to be funded in that way. We do not recommend that sort of conflict of interest, because in a way that would be an issue that would become a weak point, let alone that it might affect the recommendation. But even if it doesn't, it becomes a weak point that people can criticize you for. So it's, the issue of conflict of interest is to ensure you are not conflicted. The process is not affected by interest other than the main interest that is the intention, which is helping the people and improving health system. That's the first intention. The second intention is that you want also other people to see you are not conflicted. So it's not just that, so I'm sure I will not be conflicted. It's actually, you want to, it's like a legal process we told. We say the legal process should be fair, but it should also be seen to be fair. That's why, for example, I mean, in sort of religious stories and also, I mean, all the stories always that, so a big person went to a judge and the judge gave the same hello to the people who knew and the people who didn't know. That's to be seen that I'm fair. I'm not. So the issue of conflict of interest is really, really important. And part of the national agenda would be that to document those, put them down, what are the principles, what are the limits, knowing that, I mean, sort of pharmaceutical companies and other sources of finance are part of the health system. They are not something that do not exist. They exist, they have a role. So then you need to be able to say what are the limits, what are not the limits. So I stop here. Any questions? Any issues colleagues want to raise? Yes. Oh, I forgot also. No problem. Yeah. No, I mean, but previous time you had your hand, and also in the morning you had your hand, but so my apologies.
No problem. It's not a question, it's a comment. It's rather the one I was trying to say. I think the most important thing is the enforcing what we are trying to do. Education, CME, and blah, blah, blah are very nice and very good, and you can do it all the time, but as far as you don't have to empower this and to make it in a sort of an authoritarian way, usually we will not succeed. In the Western countries, by all means, you are not allowed by any way to buy something from a pharmacy without a prescription, even whatsoever it is, even a very trivial medication or a humble medication. You think it's a very ordinary one, and I'm not talking about an anti-cancer medications, for example. No, an antibiotic, whatever, as far as it's not over the shelf, you cannot buy without prescription. And it's totally prohibited by law, and it is forced by law to do so. So when we need to implement whatever guidelines we will reach, because actually we have guidelines in Egypt. Most of the big societies like ENT Society, Egyptian Society of Nephrology, which I'm the Secretary General of, Oncology Society, Cardiology Society, many of the big societies, they have their own guidelines, but they cannot force the stakeholders to implement. I think with the introduction or the the Ministry of Health influence now, we can do that. It's the mission now is easier because we have an authority to do so. We have many examples before. Let's say in the Egyptian Society of Nephrology, we were trying to do registry for nephrology population in Egypt, dialysis population, for the last 30 years, and none of them succeeded. Once the Ministry of Health, Dr. Khaled Abdel Ghaffar, just gave us like a couple of weeks ago his permission and a letter of recognition to do so, and he emphasized that each center should provide the data, or otherwise he will not be granted the permission to work. So all the centers now are giving us these data that we couldn't do in 30 years. So authority is important.
No, I agree. And the example of the issue you mentioned about prescription, it's not just high-income countries, let's say European countries or Northern America. In our region, not in a Mediterranean region, but for example, the case of Turkey is a good example. I mean, if you need antibiotic in Turkey, it would be extremely difficult to get it without a prescription. And a national prescription. You cannot take Egypt prescription and go to a Turkey pharmacy and sort of get your medicine. So in a way, and then the issue becomes, so let's look at what other countries have done. And even we don't have many perfect examples in our region, unfortunately, for that process, but other countries, I mean, I was shocked when I arrived in Egypt, I can say that very honestly. So first of all, I saw so many ads about pharmacies. I had never seen so many ads about pharmacy. And then there were numbers, I thought those are addresses. And they said, no, this is actually a five-digit number. You call them and they come. They come with your medicine. I said, how does it work? So it was so shocking. But then later on, you get used to it, and then it becomes part of your, then you go another country, you expect the same. I'm calling the pharmacy, the medicine comes. So this, I mean, even if it doesn't become the perfect model, moving from this to something that is much more reasonable, much more manageable, and that needs authority. One thing that one should be very careful about at the same time is that if you, I mean, I'm going to use the word force, but I don't mean that, I mean the force is a punishment always. But if you try to use force, I mean, you need to use it in a very limited way. Otherwise, people start reacting to that. I mean, if, for example, everything becomes by authority, then after a while, you realize everybody's upset. When everybody's upset, then people don't follow. So in a way, you select the areas that you really want to use the force and authority. You select the areas that you want to do education. You select the areas that you want to use incentive. And then you try to improve it better. And there are certain things that, I mean, sort of follow all those approaches. So I have 3 hands now, and yours as well. So, okay, yep, I know. Okay. For sure, yes, so then 5. So 5 hands, and then I will hand over to Dr. Naima.
Can I share with you my thoughts about our ambitious plan in dissemination and implementation? And I know if we want to implement it successfully, we need to disseminate it very well. So I think we should start with a conference after finishing our guidelines, just to open channels for feedback with physicians to know all their questions, and we start from their questions to planning an educational program to know on which points they need education. Then we can formulate our National Guideline Center website to put our guidelines inside the website and put small videos about how to use the guideline, how to read the guideline, and also we can put an icon inside the website about pathways, protocols, short notes about or summaries about guidelines that help all the professionals to understand well the recommendations of the guidelines. Also, may we put in our websites also continuous medical education system that calculate the hours of educations to all healthcare professionals on these topics of guidelines. Actually, to reach to our successful implementation, we need the support of regulations or the regulatory system, and this will be easy when we see our medical responsibility law is actually implemented. I saw also it's important to be a regulation like penalties to who didn't respond to the guideline, and also incentives to who follow the guideline to encourage. It's an evidence-based clinical practice. Also, I see that all stakeholder teams from all the different healthcare sectors can help us in training orientations for different sectors in Egypt, and they can formulate audit teams in different sectors that can follow up the adherence and get the top priority KPIs to follow if they are actually implemented the guideline.
Okay, excellent ideas. I want to identify 2 points here. So there are certain things that the center will be able to do. It's your job to do, or your expectation. You would say, if we have a national guideline, we will have a national conference after that. So you make it compulsory. The process of the review. For example, there will be a patient pamphlet in Arabic, in Egyptian Arabic, not even Fusha. Something that, for example, people, so there will be a sort of so those things, these become your generic implementation plan. But when we talk of implementation considerations, is beyond that. That is specific to each guideline. When you say about incentive, for incentive, the main thing is that you should be able to measure. So that means you need to have good indicators. When you have your good indicator, you need to be able to have the data. So that means you need to have a good data system. So in a way, that becomes specific to what area you need to consider. So I would separate the generic program that every guideline that will be issued by the national agenda would have those attached to it, and that becomes your job. Either you do it or you make sure they are done by others as part of the agenda. And the other things that become specific to guideline recommendations when that sort of the panel identify. Excellent, thanks.
The example of over-the-counter antibiotic use, this example can be managed by restricting rules or regulations. But to speak generally about clinical guidelines, it mainly entails change of behavior. And change of behavior is very difficult, especially that you are dealing with doctors and experts. So using force only will create more struggle and opposing people. So I think that during implementation, I have to create a win-to-win situation. At least I know that incentives in Egypt are very difficult nowadays, but at least I can say that every physician, if he follows the clinical guideline, he will not be liable to medical litigations. And this point, I want to raise it with the higher authorities because it will differ greatly with most of the physicians in Egypt, especially nowadays, the medical legal litigations have become a big problem.
Excellent point. Many thanks.
I don't know, I have a question maybe for the audience, but what I think, I'm not an economist, but if the prices of antibiotics in Egypt are quite lower than everywhere else in the world, it's maybe because they sell a lot. And maybe restricting the selling of antibiotics, so the companies will sell less and the prices of antibiotics will go up. So I don't know, but this is just an idea.
I'm sure as soon as you talk about any restriction in any process in the current situation in Egypt, you will get questions like this. So if the pharmacist will come to you, okay, fine, but then how I'm going to manage my financing? And then the issue of the pricing comes forward, etc. So in a way, it needs the whole system package, naturally. The main issue becomes sort of, the issue of the price of the medicine is one thing, the access of patients to the medicine is different. So by that I mean, so in the UK, the price of medicine is really expensive. But as a patient, I don't feel it because I get it free of charge. So the medicine price could actually be high, why the access may not be limited. So that's important. So I mean, we should also bear that in mind. When we talk of, so with the establishment of the insurance program in Egypt and expansion of its capacity in that area, it might actually generate also more opportunities to be able to balance those two with each other. So Liz, do you have a comment?
I mean, this has been a great discussion and really helpful. If we'd had a little bit more time, one of the key things about the book is it focuses on the reserve antibiotics, which are the ones we really don't want people to be using. And so I think the first step, and we hope this will happen in Egypt, is banning the sale of those. Because the access in the community pharmacies, so that they're reserved for ITU and under the prescription of an infectious disease physician. Because pragmatically, if you stopped it overnight, banned it overnight, that's where everybody gets their antibiotics from, and there would be an access thing for poor patients. So I think it's the political and pragmatic approach to start with the most important bits.
I think that's really important. And given that, I mean, that also applies to other certain medicines. So having a hospital list rather than a complete, and then enforcing that, because then there will be punishment if a pharmacy prescribe any of those. Okay, so, but I mean, now I'm worried about time now. So, sir, 30 seconds? Okay.
I think we follow the guidelines in big centers in Egypt, mainly European and American. We will not starting from zero or from baseline. We just modifications, which is happened every week. We make a grand round and modify the guidelines, our guidelines according to the facility and the patient individualized. So it will be, the physician will be happy to have Egyptian guidelines. It is not, it will be practical and applicable with most of physicians.
But I would also differ here. I mean, in a way, so, I mean, first of all, I mean, guideline will give you some leverage of action, etc. But I mean, you don't want that every guideline can be adapted in every single round. I mean, right now, I'm sure you know also example that if you were not in the round, another colleague was in the round, probably they might have recommended something else. So that's what the things, these are the things guidelines want to prevent. So we should sort of not mixing those with each other. Okay. Yeah. So, no, anti-TB is a specific program that is almost globally, I say almost, There are exceptions, but almost globally, TB treatments are to the but the procurement is actually different line, the approach, the distribution is different line. So you cannot do that for everything. Yeah, but that's limited. So I have a gentleman there that haven't spoken so far. So, sir, you have 1 minute because that's your first time.
I have a little question, please. If I have multiple systemic reviews when I am doing a guideline for one PICO, and I find many systematic reviews with different opinions, and I criticize them and I make all points with it, and no one of them is perfect. One has publication bias, other one not precise. How to weight, or what on which of them, or what is the main point that I will rely on to pick the meta-analysis or the systematic review that I will rely on?
I mean, this is not a common issue that you find. I mean, there will be questions for which there are a few systematic reviews. There are. And usually these are, for example, issued over time. For example, one 2020 and then another one 2020 or the years before. Sometimes they are not good quality. If a systematic is not good quality and you have a good quality, just put it aside. You don't need to reconcile. But then the issue is that if you are suspecting bias in the systematic review, and not just I didn't like the results, so then there should be bias there, is that the methodology doesn't show you the good approach, then you really need to invest to looking at the source of evidence, the analysis, looking at the table. Sometimes as a guideline program, you actually write to the author saying that I don't see you the data extraction feed. I'm representing Egypt National Program for Guideline. Can you share and we will acknowledge your support in our report. They will be very obliged to do that. They will send it to you, don't need to do it everything. And if, for example, there is a Cochrane review on the topic that matches your PICO, then start with the Cochrane review. Don't go, so you don't need to check everything then. You just go for the guideline, the review that you can trust in terms of the process. So I think I had a couple of more hands. Madam? So.
We have all difficulty in changing our practice after the guidelines. Do we have any idea of a modified form, a simplified form, to be put in the medical students' undergraduate courses, and in 10 years we will have a good practice, basic and standardized?
Yeah, absolutely. So, I mean, this should be done. I mean, I had a sort of, many years ago, the first time I did a guideline course, my description of a good guideline was that the way I described it, I thought of myself when I was an intern and was running from patient to patient, and you were worried the resident comes, ask question, and you don't know what to do, and you need to make a decision. To me, a good guideline was the one that could fit in my pocket. So something that I can take it out, look at it, and then put it back. A guideline that I need to carry doesn't help me. Right now would be a guideline that can go into my PDA, or PDA don't exist anymore. On my mobile, sorry, I'm old-fashioned. So it goes on my mobile, and I can easily search it, and I find it, or something that, so that's absolutely the case. In some, I don't know whether in Egypt you have a national formulary publication, so if you don't, I mean, that would be something to think of. But then, for example, British National Formulary, from many years ago, they started to include good guidelines in the formulary. So you open the formulary, it's talking about salbutamol use, and it says, according to the guideline, blah, blah, you should use it like this. It doesn't say this is the dosage. It says, according to guideline. And this is really, really effective, both for doctors, for patients, and also for the students. So these are the things that should follow each other. Okay, I want to stop here now because we are behind time. Yes? Yes. Okay. So many thanks, colleagues. Because I mean, after this would be Dr. Naim, I just want to thank all of you. And we enjoyed to be with you in the process of the discussion. I really enjoyed the interactions. I'm really grateful to the team over there for excellent job they've done, and the team here, so Riham and other colleagues. But the formal thanks will come from Naima. So I mean, please just take it as for those issues that, And we really look forward to the success of this program. We are honored as WHO to support Egypt in that process, and inshallah, under leadership of Dr. Naima, and the regional office will be at the service with colleagues in the country office to support you and take this forward. So Naima, this is back to you. Yeah, for the next step. You
Okay.
have to guide the
Are you
next
tired? Are you smiling? في ابتسامات كبيرة؟ في نشاط؟ في الهمة؟ وين الهمة؟ في الهمة؟ I just ask if they are smiling. You in English. Okay. Dr. Fauzi had to go with His Excellency the Minister for a meeting. I just bring a little bit of my note. I want to really thank you all. So big claps to all of you before I speak, open up way forward. Who is clapping for who? في ناس ما صفقوا. في ناس ما صفقوا. في ناس ما صفقوا. Okay, you are clapping for yourself. I will be in English so we can be fast. I asked someone to take notes because now we are talking about way forward. Way forward. Some of you, the urologist and nephrologist. Where is the nephrologist? MashaAllah, كلكم طلعتوا nephrologist. and urologist. Okay, and where is the ENT? Okay, the one. But I'm saying these 2-3 things because I told the minister, when the minister asked me that we have some samples, let them look at it to, take it as the key and to review it and apply the tool that the experts have gone with you the past 3 days. And I said to His Excellency yesterday, when I came, or the day before, say, in the groups when you were working, I saw that you are actually having ENT and urology or nephrology. So I said already they have taken this from Egypt and they were looking at it. Was I right? Not in depth, but at least you started using the tool, صح? Okay. Now, I want, before I say where is the way forward, I want to hear from you. Raise your hand and say, what do you want to see from the 4 days of intensive work, building on the previous session you had who are the committee members in the room? I know Dr. Murad. The steering committee, who are the steering committee members? One? For national clinical guideline, the ministerial committee by the minister. Dr. Mohammed Fauzi is not in the room. Dr. Mawjood? Who? Except you? Project manager. Dr. Mohammed, okay. Okay, that's what I'm asking. So we have some people who have been engaged with the, His Excellency, one of the first steps he already mentioned. His meeting last May, I'm just giving you a little bit of history. When he became the minister in November 2021, my first meeting with him was for preparation for COP27 or 26, and the second, he was already a Minister of Higher Education, Scientific Research, صح? And acting Minister of Health and Population until September 2022. So my first issue with him was, can there be a standardization? And instead of having a national guideline for X by Ministry of Health, a national guideline of X by Higher Education, a national guideline. And that was one of the first discussions we had. We praised, as WHO, the work that Egypt did with COVID-19 treatment protocol. If you look, they were the same, but still there was not having one national guideline. So this discussion continued. When he met the Director General of WHO in May 2021, one of the first things he requested from him that I want a guideline or an evidence-based approach that when we set a guideline for any care or any treatment of any disease, diagnostics, it should be a tool that can be utilized by everyone in Egypt to be for several elements, and he talked about the values. The safety, the human rights, bringing the best recommendations, bringing the best practice, based on evidence of what will work, what will not work. More importantly, to give a safe care, value for health, and value for money. That's why we brought the economists. Then he created, and they were after us, he created, after the WHO, he created a steering committee. صح دكتور مراد? صح دكتور? A high-level steering committee that has consists of several members from different sectors in health to be the high, what he calls them, the high committee to be guiding. That's where Dr. Arash Rashidian and Dr. Mehnaz were invited from the regional office, and they came actually and did the orientation. Further, they also, very good step, that Dr. Mehnaz, actually she went and met many of you, but also she saw the sites. So it was the basis for this workshop that we are talking about. However, Dr. Arash also proposed that we do a 2 days, mainly orientation, working with the high-level committee before this workshop. I am giving this a step because the same steps you will need to do for setting the specific guidelines. Is orientation, is awareness, is engagement, is bringing everyone around the table to be believer in this and also be committed and have the behavioral change that Dr. Murad was speaking about. I'm giving you this story because I want to show where we are today, and we are very proud as WHO. And I'm speaking here on behalf of my colleagues, Dr. Nathan from headquarters, and he is having a whole crew behind him. We are very appreciative of Dr. Paul coming and joining us and also contributing actively. Edith left, but promised she will join. Dr. Arash and his team, beside Mehnaz and Malika, they have been committed. He already mentioned it to the minister. That's going to be what we call a flagship, an area of work that we can show we made it. Earlier, one of the professors or one of the specialists stood and said we have it. Egypt had already had guidelines ahead of time. So we agree. But what we are talking about now is to bring the comprehensiveness of bringing the unity between the practitioners, whether in the specialty or the disciplines or the ones who are serving in the sector, and at the same time following a specific guideline. I'm giving this dibaja or al-khalfiyya because I want to go back to my next, what do I would like us from us for the coming half an hour or 45 minutes to finalize on where we want to be, from the history of where we are today. And today, if I'm not mistaken, it's the first time Dr. Lutayef is presenting عن المجلس المصري الصحي صحيح؟ صحي المصري. And he talked about the articles, he talked about what is his vision, he emphasized on the treatment guidelines and the practice. We already agreed with Dr. Arash, we will have a visit with him because we want to share what happened in this room, full of energy, full of ideas, very committed people, long hours, and contributing effectively, but also, as Dr. Arash said, critically giving critical input. مش النقد السلبي ولكن النقد الإيجابي. So these are all elements that I am putting in order to move the way forward where we want to go. Now, I want to give few minutes for all of you to breathe deeply. Deep breathe. By the way, how many of you know Dr. Arash is a very, very famous sport person? Do you know? He climbed, I don't know, Kilimanjaro, and I don't know which mountains. So when he breathes well. Did you breathe well? ما في هني ventilation, بس ما علينا نتنفس. Okay. Why I said this? Because I want you now to take a piece of paper, just think few minutes. You have 3 minutes. Just think, I'm standing here, not only representing myself, also the ideas of Dr. Fauzi. What do you want to see next step? We want your commitment. What do you want to see next step, way forward? We have discussed, but we would like, وين جماعة دكتور فوزي رفع يديكم؟ اللجنة، نائب اللجنة من نائب الرئيس من؟ ها مشوا؟ هو General authority, لجنة or general authority. Okay, just write few minutes, take a piece of paper, think, write, what do you want to see way forward? We will take it from you. But at the same time, we will come back to another question later. But now, what do you think before I open the floor? إذا حبيتوا توقفون تسوون رياضة المشكلة، إحنا عندنا بس دقيقتين بعطيكم. عشان بعدين ناخذ. أنت عندك الجواب؟ لا ما في داعي تكتب إذا عندك الجواب أوكي، بس خليهم عشان ناخذ الأكثر. أوكي. Now. أنا عندي الواي فورورد بس خلي أسمع منهم. أوكي. خلاص؟ من بيبتدي؟ ما شاء الله ثلاثة رفعوا يدهم. دكتور؟ And tell me from where you come. علشان تعرفون ال diversity. أعطوه مايك. Okay, دكتور. Give me just very short one thing, one maximum 10 words, not more. أنت كتبي.
We hope to see practical guideline go hand to hand with the Egyptian society, according to which is such a speciality. We are talking now about medicine, but I think the guideline for critical care different from the guideline in ENT or nephrology or other. For me, I am interested in infection in critical care and IV fluid in critical care, electrolyte control in ICU. Not different specialties like we discussed.
Very good. So prioritization that Dr. Arash has done before can be done again. That's one of the way, Dr. Arash, I hear, because there are so many guidelines in different areas. So yes, your interest is very clear, and that will help with prioritization. So still, maybe we need to do the prioritization. Okay. Okay, I want to give in the middle because they raised and then you. تفضل دكتورة. 10 words. دكتورة أنت ابتدي. دكتورة human rights.
Okay, just again prioritization. We need to set up the team, and it should be a representative team. And then if I'm a gynecologist, if I'm calling about the priority, we will talk about the obstetric emergency, obstetric and the gynae emergency.
Okay,
and reducing
you have now said
section
30
rate.
words. Very good. We need teams, sub-teams in the priority areas selected. Teams, sub-teams in the priority areas selected.
Kamal Etribi, co-manager of the National Guidelines project.
Can you repeat?
Kamal Etribi, yes. So the roadmap for the coming, and whether it will be from the international guideline adaptation or revising the already made Egyptian guidelines by societies.
Whether it's going to be adaptation or revision of the current guidelines. Dr. Arash, are we taking this note? Critical. Adaptation or revision. So this is one thing that we will put in the background on the way forward. Very good. تفضلي دكتورة. أنت مع دكتور فوزي صح؟ لا؟ أوكي.
أنا دكتورة سواء أحمد، أنا أستاذ أورام في جامعة السويس. هو
University.
Yep. I think let me say it. Not all of us, when we attended here, was cleared about the goals and the objectives of this workshop. Actually, we end up to know by the second day. So for me, from the start, I need a clear orientation and visualization of what's going on, because I know that many of our colleagues doesn't know what's going on in the government. Yeah.
Yes, thank you very much. And I was very pleased when Dr. Lutayef today, he gave عن المجلس.
To us, but not to everybody.
But he will give. نعطي مجال للأستاذ دكتور بعدين أرجع لك. Please, anyone raise their hand here? ما فيش.
Many thanks, Doctor. Dr. Ahmed Adib, consultant for hepatology, gastroenterology at National Hepatology Institute. We need to enforce clinical guidelines as a culture in our healthcare organization. We need more stakeholder buy-in as regarding pharmaceutical companies, media, civil unions, patient representatives, not just to be an elite level guidelines, and the other stakeholder or other practitioner are not participating, you are not having the same vision of our project.
Excellent, that we do need to have representation. And I was very pleased to hear from Dr. Lutayev that anything in future, teaching, capacity building, clinical practice, policy making, there will be representation. I put it in my note, stakeholder, for example, patients or their families or their practitioner. And here, practitioner, we are not talking about one discipline in the healthcare team, but we are talking about multidisciplines. And when I say multidisciplines, it's not physicians specialized. It's actually disciplines of pharmacy, nursing, radiology, physiotherapists, sociologists, okay? And that's very important points that Dr. raised. Dr.? So how many way forward we have? Khali, I'll way forward.
What I really want to see is a clear-cut timeline about the whole process,
yes,
with a clear-cut outcome,
yes,
tasks, who will be doing them, who doing them where, and when to be done, and milestones for assessment, and external assessors of what we are doing to monitor the whole process.
External assessors of what we are doing. The WHO colleagues from headquarters and region, external assessors what we are doing. This is something that initially His Excellency requested, and this is something we will put it, but we need to look at it, what do we mean, and how to define it. It could be internal also, but we have a continuous measurement. Thank you, good. اتفضل دكتور.
I'm Ahmed Abdelaziz from National Heart Institute, Gothi. One of the most important things that we want to survey the current practice from all the physicians in the guidelines we are going to practice, to see what's going on the ground, and to know what we want to modify and why physicians are doing this, to modify it or not.
Excellent. Already I know some work has been done by Dr. Mohammed Fawzi and the team. Dr. Arash can confirm, because I remembered some situation analysis was given, the SWOT analysis, but this is something that could be strengthened. We will put it in one of the agenda items for the plan for the way forward.
There are just 4 points. The first of them is to unify our practice by the multidisciplinary team, and that was perfectly discussed right now. The second part, the implementation, practical implementation at all health service levels. We have different levels of practice, so we need to implement it at the different levels. The third thing is the maintenance. How can we maintain our new regulations or modified regulations? Would there be legislations, for example, different modes of that, and the consolidation with re-evaluation? So these are the 4 points that I'd like to be.
Some of them has been said already by the previous colleagues. Dr. Kauthar, and then you could say. Okay, we'll take few more.
We already have clinical guideline for nursing, but we need to update after of this workshop. We'll follow the scientific regulation, but I want both mechanism for wide dissemination and, as Doctor said, implementation. And ربط في auditing أو related للaccreditation ربط implementation بتقييم الأداء. شكرا.
Thank you very much. Dr. Kauthar brought in terms of performance. His Excellency mentioned it in his speech. I made a note. So we are doing this not just because we want to have a national guidelines to say we have it, to practice it, to implement it, to follow it, to measure it, and at the same time to really bring the performance from the angle of Dr. Sharif when he mentioned patient safety, people receiving care, but also from the services. Dr.
I think from the subspecialty we are deciding to start guideline, we have to start to identify the most common problem related to collect the evidence base and appraise this evidence base to start to adopt and adapt for.
Okay, now we are starting. Okay, Dr. Nabil Duwaydar, and then yourself. Where is the other mic? We have so many mics. Where are they? Yes, working?
We got one here. I would recommend to think of to work more on capacity building and also to work more on identifying the local national capacity, because I think there is capacity in the country, but it's not really engaged, and to see why they are not engaged and how they can be engaged. And also the concept of piloting. I'm very worried about this sort of massive approach to the whole initiative. I think we also have to think about piloting. As far as knowledge creation, the development of the guideline, and also maybe choosing one of them to pilot the implementation within a controlled environment, let's say within the Ministry of Health, to see how we can apply these guidelines. So piloting and capacity building, I will put it.
Thank you very much, Dr. Nabil. Dr.
Dr. Mohammed Al-Gohri, consultant of Tropical Medicine, Ministry of Defense. This is the second workshop that I attend, and before the workshops, there is many appointments that hold in the with Dr. Mohammed Al-Souda. I think our scope is clear enough. We have many guidelines from the different societies that already finished. We can depend on, and we are not starting from the scratch. We can, starting from with these guidelines, we can using the informations and the help of the WHO teams to update and good formulation and regulation writing for these guidelines. I think within few months we can succeed to make many guidelines for many issues, and then evaluating the troubles, then implementation, and evaluating the feedback.
Thank you very much, Dr. How many of you believe we do not need to start? We have a lot at hand that we can look at. We believe that there are already work has been done. There is a lot already of good work. Yes, and then this is a good step. So it's a positive step. So we are not starting from zero. And that's what Dr. Arash and Dr. Nathan and Dr. Paul were trying to bring, that we already have, we just need to look at it, to improve it using a systemized tool. And instead of everyone is using a different tool, we use it a systemized tool and see whether maybe some of them just need little bit of tweaking. Maybe some does not need anything, but it will be taken for review, as His Excellency mentioned, and then it will be taken for approval by the magistrate. And already he put the mechanism, صح? This is what he already put the mechanism on where we can. So there are during the break with Dr. Arash and the team, we were talking about the low-hanging fruits. So already we can have some work demonstrated. We are not starting from zero, and that's one of the key messages as WHO we want to assure you. Tfadal, Doctor, you have been raising your hand.
Mohammed Al-Atrebi, Head of Urology Department, Sahel Teaching Hospital. It should be simplified to be applied, adhere to European and American with adaptation according to our circumstances, into consideration with patient safety with minimal cost. And I suggest that it should be applied at first on big centers before published to all over the country, to evaluate before be published to be applied on over the country.
This is the review that the minister was talking about. So review, implement, and then we. But one thing that we want to show, and I think it was in the presentation of Dr. Nathan when he said, when new things comes, we move. You know, I remember we were told that the life of the knowledge is a year and a half. Yes, a year and a half. Now the life of knowledge is maybe a few hours. Just today, there is some announcement about the HIV/AIDS vaccine, for example, that has passed the human trial. So immediately, the whole EPI things would be changed. And that's the fluidity that we are talking about. Still, it will be there, and we are bringing the science through review, through monitoring. And I did not hear from anyone on the use of the technology, and especially digitalization, to disseminate. And that's, I'm sure it's coming to the team. Okay, I'm told that I can take a little bit more ideas, and then
أنا دكتور ضياء الدين عبد المولى, consultant emergency medicine and head of emergency department في MOHP. This is the second workshop I have attended, and this is a dream that, as my colleagues and the professors have told before. It is a dream to us to have a national clinical guidelines, but I will not add more than they spoke. We have a situational analysis to the current situation we have. We have already guidelines. We have to review it as you mentioned, but we have to have a time frame for each step we will do next. A time frame for the next steps from the start, from the scratch. We will do the next step on that X and the so forth. Second thing, I think we have to start with the prioritization with the most important topics in each specialty as a pilot study, and to implement them and to measure how they are efficient and effective, what the impact of them. The last thing, we have to have a criteria for team selection and a way to maintain the project. Whatever have done, we have a program, a project. We have to make a maintenance plan for it.
الاستدامة resources. I always say Egypt has loads of resources. It's how the resources are used. Loads of resources, brains, expertise, knowledge. I'm not talking only about material and buildings. And how we are going to use it. شنو? Team dynamics, thank you, finally it's coming. Team dynamics is one of the key critical core for the way forward. Okay, anybody else has something to say? Okay. 1, 2, 3, what did you write? هي عايزة تقول حاجة and she's reluctant.
I want to say that it's important to make education to the healthcare workers about the importance of national guideline and why it's different from American or European guidelines, and being national guidelines not meaning it's not professional, but it means more specific for our country and our population, like the example said by Dr. Paul about zinc deficiency in some places, and that's needed to be supplied to patients with diarrhea, while in other countries it's not recommended. So we need to educate healthcare professionals about our healthcare workers about the importance of national guidelines, to be waiting for it. And there is passion about using it. Not be surprised that's national guidelines and you should follow it, and reject and feel resistance to the guidelines.
Now, how many of you had resistance? I'm just going to build on this. How many of you believed everything is perfect, we don't need this workshop? لا تخافون ما حد بيشوف. How many of you believe that there is resistance? Okay, show of hands. I don't know whether Paul and Arash are seeing the show of hands. Many believe there are many people resistance, but all of them who are here now convinced. So that's good. Okay, now this is one of the critical core of way forward. I can tell you because we can go like traditional. I was just standing here looking at my team who are all sitting here also, and looking at Dr. Arash and the team from headquarters and region, and I'm saying, Naima, as a WHO representative, we just come and say, we are supporting. And I decided that I will go at what I'm known for, non-traditional approach. Yes?
One of the objectives of this workshop is training of the trainer to the other healthcare workers to adopt and make new guidelines come to أرض الواقع يعني تمام. how well the trainers in this قاعة will train other health workers. Will it be organized by the WHO or Ministry of Health or individually?
Critical question. Thank you very much. A big clap for her. Because I think this question of training of trainer is a long process. It's not just this, but this is a beginning. Right, Dr. Miras? Yes. Dr. Iham, it's a beginning. We have recorded everything for you. So very, very critical question. All of you have been already in several settings. It's not new to you. But now what we are saying, أول شيء الالتزام. أنا بديت بالهمة. الهمة موجودة صح؟ الهمة, commitment is there. But at the same time, التزام, commitment, and derive. The training, this is a start. It's not ending today. العلم من المهدي إلى اللحدي. هاي علمونا من وإحنا صغار. صح? So today, this is one of the critical core. What is after this? It's just this workshop, which has been a kind of training on the tools and assessment. خلاص, and then we leave you. This is something, that's why I wanted to hear from you. مع Dr. Fauzi, these are one of the way forwards that already Dr. Arash and his team are working with us to bring a consultant, to be working with, as an international, to be working with the committee and the structure that we built to actually start moving forward. So it's the beginning. Okay, this is one of the things. We are also, as WHO, committed, beside Dr. Riham and a couple of colleagues in the room, that we will have people, some of the experts like you, to be working in the different prioritizations when the prioritization is decided. If it is obstetric and gynae, if it is infection control, if it is ENT, if it is cardiovascular. So there will be, definitely prioritization will continue, but at least we need to start somewhere. And I want to go where we start somewhere. The third, which already I promised Dr. Fauzi long time, and still yet we were waiting for this workshop, is to have already the guidelines that we just heard from Ministry of Defense. They're already there. And there is a belief that they are strong. We bring the committee, we say the experts as support to review selected ones. Dr. Riham, I'm looking at her because Dr. Fauzi gave us 140 clinical guidelines to review. So we start with a couple of them that already you believe is good, using the process that we learned with the tool, and that is a workshop, it's a committee, it's a regular meeting, and then we say that's another step. So we are going to support international consultant, experts from the team, the group of meetings that's coming, visit to the center. There is a center that has been established, Mataria Hospital. Yes. Mataria Hospital, this is the way forward. But it's not the visit to the center, it's actually visit with the team and how to approach all of you who have been here. That's part of the communication that will go. But the visit of the center is not by me, it's by me and people from the regional colleague that coming, Dr. Arash and Dr. Mernas and others. And this is another step that we are doing. The committees, there are different, but at least we said, let's start with few. Don't have so many committees that we cannot control. The video recording that has been happening, it will be shared with you. I believe something is already online that you are receiving. So that's another follow-up. And one of the questions, I think Malika has put it, we will be asking you, what will you do? What will each one of you do? You have yourself, you have your team, you have your colleagues, you have your peers. I don't know how many students are here. How many students are in this room? I'm a student. Okay? But I'm talking about people who are studying already master degree, PhD degree. These are students, right? Specialization. So these are few steps that we are going to go forward with under the guidance of His Excellency the Minister. And we are now having also His Excellency guided that we need to work with the Minister, with Dr. Tayyef as a new entity. Some of the points you raised, it needs to be written into the principles of work, like social behavioral change. This is a value system. Like, for example, institutionalization is a principle system. How can we put institutionalization in the work that we are doing? However, more importantly, many in different ways say let's need to assess what we have. This work has been done, but we need to scale it up. What is the situation? Has ENT thing that was shown to us has taken all the measures that will put the criteria. That's something that the review group will be doing. These are critical ones that I want to say that we see as way forward, that I quickly discussed with Dr. Fauzi and His Excellency the Minister. Already as WHO, we are committed that there will be a pre-regional committee meeting, which is held in October, that this would be on this development of clinical guideline that Dr. Arash mentioned today. It is under his leadership as a regional director in the region for this area, and it will be a day before the Ministers of Health meeting. Now, with our headquarter colleagues, they will be with us working continuously, and we will have three people talked about roadmap, timeline. This will be timeline. The international consultant is already processed. Some of the national consultants are already in the process. So we are already taking action, not waiting. For the last 3-4 months, there has been active work by the team. And what will happen with Dr. Fauzi, we'll be seeing it more and more. There will be next week, I believe, a high committee that he has to be working. Dr. Nathan will be with us, not necessarily every day. I want him to come be here in Geneva, from Geneva in Cairo every day. The same with Dr. Arash. Dr. Arash and Mehnas actually received permission, visa to come from Nasser City to Egypt, Arab Republic of Egypt, right? So this is I'm giving because many people do not know that we have a country office, 22 country offices in the region. Egypt is privileged to have 2 offices. Egypt, one of the 22 countries, and the regional office. I'm saying this because until today I received confusion. People are writing to the regional office and asking for things that should come through here. So it's lose time. It goes through a whole process. And this is very critical. At this point, commitments that we have made, I put it in very specific. I requested to have the typing your points because I want you to be ownership. My last message, we are in this together. I've already requested Dr. Paul to think and be with us, inshallah, in future. The same with Edith as health economist, because we believe, and Dr. Ahmed Khalifa, our health economist, is there. We believe as health economists is very critical for the value, and we have a team. We have brought someone else. I don't know where is she now, Raneen. And definitely you see that I brought WHO team. By the way, this is all WHO team. We are not more than this. Right? Almost everyone is in the room, except Hala and Randa. صح ولا لا وأميرة وعمر. 4. So they are here because I wanted all of us to be the students, to learn A to Z, and Doctor, your contribution has been great. Learn A to Z so we can support and have the same language. I have learned very early on, common language doesn't mean the same meaning, the same understanding. Shared language doesn't mean the same meaning, the same understanding, the same comprehension. But now when we are in this room, we will have the same understanding, the same comprehension. I want to thank you now. I will wear my other hat. I would like to thank everyone who contributed. I'm bringing also the message from Dr. Mohammed Fauzi. We are finalizing the session. There will be a short questionnaire. And I want to really, really, really appreciate. I'm very glad that I managed to join most of the session. Initially, it was planned to be the whole 4 days, a student like you sitting in the room. However, I learned a lot from all of you. We, as WHO country office, will be working with you closely. You already know, met the team, most of them. I would like to thank Dr. Riham. She has been really, really working hard to make this happen. Behind the scene, front the scene, working with all of you. Definitely, there has been a backup, and I want to really also thank Mehnas because she has been also giving us her time and coming and virtually working on that. Definitely, there are behind us Ahmed Hashim and Mahmoud, who has been the secretariat. We should give clap to you again, as I said, and then we have the team, the WHO team. We have the health system teams, universal health coverage, they are here, whether it's Jasser, whether it's Amira Hijazi, whether it's Ahmed, and definitely we have what we call the health security group and communicable diseases. This is Dr. Areem, Nahla. I'm just introducing the team because maybe you don't know them. Nuha and Nuha Hayek, we have 2 Nuhas now. Either we have 3 names, the same names, and then we have Salma. So I want to thank everyone. But mainly thank you. I just introduced the WHO team for a reason. Yara is here, and already you met Elizabeth. When Ahmed Surur? طلعت? Okay. Okay. I will tell you a story now to laugh. I told them, صح ولا لا؟ انتشروا. طبعا هو لم ينتشروا. يجلسوا كلهم في نفس الطاولة. I wanted them to be in different tables so they know you more and you know them. You know what are they doing and what we are doing in Egypt. We are a small agency, and we are very proud to be working hand in hand with the health authorities in Egypt. Our contribution might be 0.0001, but what I say to our stakeholders, as WHO, our contribution sometimes is putting the seed, influential, and then Egyptians will run. We don't need to stay to do on the same things, because خلاص, you are running and you are taking the lead. And we see Egypt is the largest Arab country, influencing, and this is WHO, even my boss, Dr. Ahmed al-Mandari. And at the same time, we are seeing, who is the regional director, we are seeing Egypt set examples, and that's why we are talking about the example of this clinical guidelines. So we are very proud. I'm sure you are more proud than us, but we are very proud that we have started this. And inshallah, by October, we have great achievements. I'm looking at the team here. And by end of the year, we will have several guidelines approved by مجلس الصحي المصري. صح؟ يلا تصفيق. Thank you.
Dr. Naima, I just want to say a big thank you to Dr. Naima for your huge support for this program. And I really feel that it's becoming your own dream. Also, a big thanks to all professors for their detailed and clear presentations. And Dr. Reham Al-Asadi, a big thank for the perfect organization of this workshop.
Thank you. Yeah, please, thank you. Thank you, Dr. Naima, for the excellent concluding remarks, as always. So we will have, I want to again say thank you for you to being with us, and being with us for these 4 days. So we will have a very, very, very quick evaluation, which includes just 3 questions, 2 closed questions and 1 open-ended question. So we would be very grateful if you can just contribute to this part of workshop, because your feedback and suggestions and recommendations or complaints would be very, very, very welcome and help us for our future program that we will have for Egypt. But while you are just going to use this, you can use your QR codes if you have on your phone, or you can just go through slido.com and use this passcode, and then you will be able to see the questions, and we will start it. So while you are doing this, I would like to ask our professors and our trainers, Dr. Paul, Nathan, and Dr. Arash, for any, comments, feedback, if you have, please.
Thank you so much. It's been a privilege being with you, and I respect the progress that you're making. We clearly got political commitment and fantastic capacity and willingness to move forward. In fact, many of you understand the principles of what we've been talking about. So it's been my pleasure to be with you. Thank you.
And similarly, I don't really have anything to add except to say that I've really enjoyed the dynamic and the enthusiasm and the engagement and the questions. It's really been a very engaging few days. I'm sure we're all quite tired now at the end of day 4, but up until the end, you've been fully engaged, and so I've really enjoyed my time here, and I thank WHO for inviting me to participate, and I thank all of you for your energy and engagement. Thank you.
Yeah, I haven't got anything in addition to say. I said a few words before, just a response to what Naima said earlier. So it's our pleasure. When we are in the country office in Madinat al-Nasr, we are in Cairo. No, sorry, in the regional office in Madinat al-Nasr. So you see now I'm already with the country office. So when we are in the regional office, we are in Cairo. But here, أنا في مصر. So the old name for Qahira is Masr. So we are coming from Cairo to Masr, and it's a pleasure. Yeah, thank you.
So I can just add that I love your country, and I mean your history country. Okay, so now we can just start questions. The question number 1, it's not shown here, but you know, colleagues, you can see just the questions. Oh yeah, it's coming. So please rate the quality of the workshop. It's from 1 to 5, 1 least, 5 most. So. So still we are receiving your feedback, so we are waiting to see when all colleagues just entered the answer. So thank you. We got 4.4 out of 5. Thank you so much. This is very great. Thank you. So we can show maybe. So the next question, Malika, please. So the next question is, would you suggest similar workshop for other colleagues in Egypt? Yeah, in Egypt. Yeah, 90% just answered yes. Thank you. And the last question, which is a kind of, it needs your patience because it's open-ended question, so it needs to write just some sentences, which is, what will you do to support this program, for establishment of this program in Egypt? Thank you. What do you think, what would be your role in this regard?
It is individually and as a team. We couldn't divide the questions, so you can say, I will do 1, 2, 3, and short. Don't make it very long.
Thank you so much. We have 13 participants are still typing, so we will wait to colleagues finish writing. Okay. Again, many thanks for your great contribution to this last work. Sorry? Thank you. So we will wait till when you want. So I just want to hand over to Riham for ending the session.
Thank you so much, Marnaz. I usually don't end anything when my boss is here. So it's either me or my boss. But thank you all so much. I really appreciate the last 4 days were excellent. Of course, great work by our colleagues and our experts. Nathan, Paul, Dr. Arash, Marnaz, thank you so much for being with us and for helping us. And of course, Edith, my best regards to her. Hopefully we will meet again soon as you support us more. Thanks to all of you, of course, for the great work. Thank you to Dr. Fawzi for his excellent commitment and Dr. Fawzi's team for excellent coordination and for working very closely with us. I have to say that Dr. Naima is pushing us all the time for this particular program and for many things related to Egypt. As a matter of fact, I always say she cares more about Egypt than an Egyptian. She's very, very much involved with us. So again, you made it so wonderful. You made the level of engagement amazing. And I'm extremely proud of this team. So thank you so much. I look forward to meeting again very soon, inshallah, and carrying on the process. Thank you and enjoy. If I can please ask you to individually kindly take your certificates if you haven't already, and lunch will be served in a few minutes. Thanks.